Hello and welcome to your ultimate guide for your CCMA exam. My goal today is give you everything that you need to understand the full concepts, master them and walk you through the CCMA exam with total confidence. In this video we will cover patient management, clinical procedures, emergency response, administrative ethics, applied anatomy, and remember our website helps you to practice your CCMA exam with our practice questions, timed mock exams and study guides. You will find the link in the description below. So let's get started.
Question 1. A patient with multiple chronic conditions is scheduled for a 30-minute follow-up. The patient also requested an interpreter. What should the medical assistant anticipate when scheduling? Your options are: A. The visit may take roughly twice as long. B. Telehealth always extends visits. C. Pediatric visits never run long. D. Wellness visits require minimal time. Which one is it? Pause the video if you need more time. The correct answer is A. The visit may take roughly twice as long. A is correct because interpreter-assisted visits often take roughly twice as long because each statement is translated. Practices typically build in extra time and document language and interpreter use for compliance with language access standards under federal civil rights law. B is wrong because telehealth visits often run shorter rather than longer, especially for established follow-ups in primary care. Telehealth typically uses shorter time slots for stable follow-up encounters scheduled in the practice's templates for video or audio-only visits. C is wrong because pediatric well-child visits often extend past the standard slot due to growth, development, screening of, and immunization counseling activities. They are typically scheduled for longer time slots rather than shorter ones in pediatric practice templates and workflows. D is wrong because annual wellness visits require longer time slots for the comprehensive screening battery required by Medicare. They are time-intensive rather than minimal, given the components Medicare requires for documentation and review during the encounter with the patient. When a patient needs interpreter services, scheduling that visit requires more than just finding an open slot. The time math changes in a predictable, mechanical way, and understanding why helps you build a schedule that actually works. 3 mechanical factors drive the time increase. First, sequential interpretation requires turn taking that adds dead air between each exchange. Second, medical vocabulary often lacks direct one-to-one translation, so clarification is needed before relaying. Third, teach-back comprehension checks take longer across a language gap than in a single language encounter. Visualize the time block itself. In a standard 30-minute visit, the provider fills most of that time speaking directly with the patient. Add sequential interpretation and every exchange must run twice, in both directions, cutting each party's effective speaking time nearly in half. Language access isn't just a scheduling courtesy, it's a federal compliance requirement. Title VI of the Civil Rights Act and ACA provisions require covered entities to provide qualified interpretation at no cost. Practices must document the language preference, the modality, and the interpreter identifier, and they must allocate enough time for the encounter to actually succeed. The takeaway is straightforward. Whenever a STEM pairs multiple chronic conditions with a language access need, the correct answer points to doubling the time block and documenting the language service. A 30-minute slot for that encounter sets both the patient and the practice up to fail. Question 2. An aging report shows several patient balances over 120 days old. What should the medical assistant do first? Your options are: A. Send the accounts to outside collections. B. Verify insurance and rebill if needed. C. Write off all uncollectible accounts. D. Discharge the patients from the practice. Take a second. Which answer would you pick? The correct answer is B. Verify insurance and rebill if needed. B is correct because before escalating to collections, the medical assistant should re-verify insurance, ensure statements were sent, and confirm the balance is truly the patient's responsibility. Many old balances reflect missed coverage updates or coordination of benefits issues found later. A is wrong because rushing to outside collections without verifying the bill may damage patient relationships and risk Fair Debt Collection Practices Act issues. Verification first protects the practice from sending an incorrect balance to a third-party collector by mistake. C is wrong because automatic write-offs lose recoverable money for the practice. Aging accounts deserve proper review for missed coverage, coordination of benefits problems, and statement delivery before being abandoned as uncollectible in the practice's accounts receivable management process. D is wrong because discharging patients for unpaid bills must follow practice policy and state-specific abandonment rules. It is not the routine collection response and is unrelated to verifying the accuracy of the bill before the next collection step is taken. In medical billing, aged accounts follow a strict order of operations. Before any collection action is taken, the medical assistant must first verify that the balance is actually the patient's responsibility. A balance showing as patient responsibility may actually trace back to a coordination of benefits problem, an outdated insurance card, an unworked denial code, or a statement that never reached the patient. None of these are true patient debt. The clean aged account workflow starts by pulling the account and re-verifying insurance through the payer portal, then checking for unposted payments, confirming statements were delivered, and only then determining the balance is genuinely owed. Collections, bad debt write-off, and patient discharge are all downstream of verification. Mixing these up leads to answers that sound decisive, but skip the accuracy check that protects both the practice and the patient. On exam day, when the STEM asks what the medical assistant should do first with an aged account, the answer almost always points to verification, checking insurance, rebilling, or confirming statements, never the most dramatic action on the list. Question 3. A patient says she suffered from pyrosis after dinner. Which of the following is the correct lay translation of this term? Your options are A. Heartburn, B. Bruise, C. Itching, D. Ringing in the ears. Before I reveal it, which one do you think is right? The correct answer is A. Heartburn. A is correct because pyrosis is the medical term for heartburn, a burning sensation behind the breastbone often related to acid reflux. Translating jargon into plain language helps patients understand their records and supports better self-care and follow-through. B is wrong because bruise corresponds to contusion or ecchymosis rather than to the burning chest sensation that pyrosis describes. So it would miscommunicate the patient's symptom to anyone reviewing the chart entry without further context provided. C is wrong because itching corresponds to the medical term pruritus, a skin sensation, and has nothing to do with the chest discomfort that pyrosis denotes. So it would not capture the patient's actual complaint in plain language for the record. D is wrong because ringing in the ears corresponds to tinnitus, which involves the auditory system rather than the burning sensation pyrosis names, and would mislead anyone reviewing the chart about the body system actually affected by the symptom. Medical terminology exists for one reason: precision. When a clinician writes a technical term on a chart, it carries an exact, standardized meaning that travels across borders, centuries, and languages in a way that everyday words simply cannot. The key to decoding unfamiliar medical terms is root analysis. Pyrosis breaks into pyr, meaning fire or burning, and osis, marking it as a condition. The same root appears in pyrexia and pyromania, so recognizing pyro instantly unlocks the meaning even without prior exposure to the word. Exam writers exploit look-alike and sound-alike terms anchored to completely different body systems. Pyrosis, pruritus, tinnitus, and contusion all name real symptoms, but each belongs to a different system. Reading the root out, not just the prefix, is what separates the correct answer from the distractor. Technical and lay terms coexist because each serves a distinct role. Greek and Latin roots give the medical register cross-border stability and support precise coding and indexing. Lay terms remain essential for patient communication, which is why medical assistants must translate fluently in both directions every single day. On exam day, whenever a STEM asks for the plain language meaning of a medical term, anchor your answer in root analysis. Distractors will name symptoms from unrelated systems, hoping you confuse a prefix or suffix. The roots tell the story. Question 4. 5 minutes after a penicillin injection, a patient develops widespread hives, audible wheezing, and falling blood pressure. What should the medical assistant do first? Your options are A. Give oral diphenhydramine immediately. B. Administer intramuscular epinephrine into the thigh. C. Place the patient prone and apply oxygen. D. Step into the hallway to call the family. What's your answer? Commit to one before I continue. The correct answer is B. Administer intramuscular epinephrine into the thigh. B is correct because intramuscular epinephrine into the vastus lateralis is the first action in anaphylaxis. Antihistamines and corticosteroids are adjuncts that follow, and emergency response is activated alongside epinephrine, not before the first dose is delivered to the patient. A is wrong because oral diphenhydramine acts too slowly to reverse airway swelling or hypotension and cannot replace the airway saving cardiovascular effects of intramuscular epinephrine in an actively progressing severe reaction in clinic today. C is wrong because prone positioning is not recommended in anaphylaxis, supine with legs elevated, or upright if the patient has severe respiratory distress, is the preferred position during initial management and stabilization in clinic. D is wrong because delaying critical interventions to call family abandons a deteriorating patient and does nothing to reverse the airway and circulatory collapse occurring from the anaphylactic reaction in real time today. Anaphylaxis is a severe, life-threatening allergic reaction involving multiple body systems at once. Understanding why it happens and how to reverse it is the key to acting correctly in the critical first minutes. Anaphylaxis is identified by its hallmark multi-system involvement. When hives or angioedema appear alongside airway swelling and a falling blood pressure, all within minutes of antigen exposure, the diagnosis is anaphylaxis, not a localized reaction. The danger originates in mast cells, when antigen binds to IgE on mast cell surfaces. Massive degranulation floods the circulation with histamine, tryptase, and leukotrienes. Histamine alone drives vascular leak, bronchospasm, and urticaria, explaining why the cascade can close the airway and collapse blood pressure so rapidly. Epinephrine is the only agent that reverses the entire cascade at once through 3 receptor systems. Alpha-1 effects restore blood pressure and reduce airway edema. Beta-1 effects increase cardiac output, and beta-2 effects open constricted airways. No antihistamine or corticosteroid can do all 3. The dose is 0.3 mg of 1 to 1000 epinephrine given intramuscularly into the vastus lateralis. This site absorbs faster than the deltoid or the subcutaneous route. Antihistamines and corticosteroids follow as adjuncts. They never replace the first injection of epinephrine. Question 5. A patient on warfarin asks the medical assistant whether to stop eating salads because greens contain vitamin K. Which of the following is the most appropriate response? Your options are A. Stop all leafy greens entirely. B. Eat unlimited spinach daily. C. Keep intake of greens consistent. D. Switch to grapefruit juice instead. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Keep intake of greens consistent. C is correct because patients on warfarin should keep vitamin K intake from leafy greens consistent rather than eliminating them. Sudden changes in green leafy intake destabilize the INR and increase bleeding or clotting risk during anticoagulation therapy. A is wrong because eliminating leafy greens removes valuable nutrition from the diet. Consistency, not elimination, is the recommended counseling approach for patients managing anticoagulation with warfarin therapy on an ongoing daily basis over time. B is wrong because suddenly increasing leafy greens raises vitamin K intake and can lower the INR below therapeutic range. Consistency in dietary vitamin K intake keeps the warfarin dose response stable and predictable for patients on anticoagulation therapy. D is wrong because grapefruit affects medications metabolized through CYP3A4, such as certain statins, and is not a safe substitute. Switching beverages does not address the warfarin and vitamin K relationship that prompted the patient's original question to the medical assistant. Warfarin prevents dangerous clots by blocking a key liver enzyme, but its effectiveness depends on a dietary factor that many patients misunderstand. Understanding the mechanism makes the counseling advice intuitive rather than arbitrary. Warfarin inhibits vitamin K epoxide reductase, the enzyme that recycles vitamin K into its active form. Without active vitamin K, the liver cannot produce clotting factors 2, 7, 9, and 10, nor proteins C and S, slowing coagulation overall. When dietary vitamin K suddenly increases, 1 from a week of extra leafy greens, it competes with warfarin and pushes the INR down, raising clot risk. A sudden drop in vitamin K leaves warfarin unopposed, driving the INR up and raising bleeding risk. The solution is consistency, not elimination. A patient who eats roughly the same amount of leafy greens each week gives the prescriber a predictable baseline to dose against. Any sustained level of vitamin K intake, low, medium, or high, can be successfully dosed around. On exam day, when a STEM pairs warfarin with a dietary question, the answer almost always points to consistent intake rather than eliminating or maximizing greens. Patients on direct oral anticoagulants like apixaban need no such counseling. This conversation belongs to warfarin alone. Question 6. A medical assistant is reviewing autoclave compliance. Which of the following best describes the recommended frequency of biological indicator testing in a primary care practice? Your options are A. Yearly biological indicator only. B. Weekly biological indicator testing. C. Once at initial purchase. D. Whenever staff feel concerned. Which would you go with? Lock it in before the reveal. The correct answer is B. Weekly biological indicator testing. B is correct because each autoclave load is checked with chemical indicators, and weekly biological indicator testing confirms sterilization effectiveness for the device. Documentation of cycle parameters and indicator results is required for compliance with infection control and accreditation standards. A is wrong because yearly testing is far too infrequent for biological monitoring of the autoclave. A failed sterilizer between annual checks could compromise instrument safety for many patients across many encounters between the scheduled biological indicator tests of the device. C is wrong because one-time testing at purchase ignores the ongoing risk of mechanical or chemical failure during regular operating cycles of the autoclave. Routine recurring biological monitoring is the standard for sterilizer monitoring during ongoing clinical use practices today. D is wrong because subjective concern is not the trigger for biological monitoring of the autoclave. Standardized routine testing on a defined schedule is required regardless of staff impressions about how the autoclave appears to function during routine instrument processing each day. Sterilization sits at the top of the disinfection hierarchy. It destroys all microbial life, including the most resistant bacterial spores. Any instrument that enters a sterile body cavity or breaks the skin must be sterilized, and the standard outpatient method is steam autoclaving. Monitoring works in 3 layers. Mechanical indicators are the machine's own gauges. Chemical indicators confirm the load was exposed to steam. Biological indicators, containing heat-resistant Geobacillus stereothermophilus spores, are the only layer that directly proves sterilization actually occurred. After each biological indicator run, the processed vial is compared to a positive control that was never autoclaved. A clear processed vial means no spore growth. Sterilization succeeded. If the processed vial turns yellow, the autoclave failed, even if the chemical indicator passed. Frequency is the most tested detail. Biological indicators run weekly in outpatient setting, plus after any repair, after implantable device loads, or after a failed chemical indicator. Chemical indicators go on every single load, and mechanical indicators record automatically with every cycle. Remember, yearly biological testing is far too infrequent, and one-time testing at purchase ignores ongoing risk. The CDC standard is weekly spore testing, and documentation of every result matters just as much as the test itself. Question 7. A medical assistant is verifying the calibration mark on a routine 12-lead EKG before recording. Which of the following represents the standard calibration pulse? Your options are A. 10 mm tall and 2/10 second wide. B. 5 mm tall and 1/10 second wide. C. 20 mm tall and 1 second wide. D. 1 mm tall and 1 second wide. Don't overthink it. Which one feels right? The correct answer is A. 10 mm tall and 2/10 second wide. A is correct because the standard calibration pulse on a routine 12-lead EKG is 10 mm tall and 2/10 of a second wide, with paper speed 25 mm per second. Verifying it confirms voltage and time accuracy before interpretation. B is wrong because 5 mm tall represents a half standard pulse and would indicate gain has been deliberately reduced for very tall complexes rather than running at the routine baseline calibration setting used clinically every day. C is wrong because 20 mm tall is a double standard gain mark, sometimes used to magnify low voltage tracings, but it is not the routine baseline calibration applied during typical office EKGs on healthy adults at the visit. D is wrong because a 1 mm pulse over 1 second does not match any standard EKG calibration setting used in clinical recordings and would prevent meaningful interpretation of waveform amplitudes by the provider afterward during review. Before any EKG can be interpreted, the machine's two core settings must be verified: paper speed and voltage gain. The calibration pulse printed at the start of every tracing confirms both axes are correct. The horizontal axis encodes time at 25 mm per second, and the vertical axis encodes voltage at 10 mm per millivolt. If either setting drifts, every interval measurement and amplitude reading on that tracing becomes unreliable. The standard calibration pulse is a rectangle precisely 10 mm tall and 2/10 of a second wide. That is 2 large boxes vertically and 1 large box horizontally on standard EKG paper. Its shape is the fingerprint of a correctly calibrated machine. When QRS complexes are so tall they bleed into adjacent leads. Half standard gain shrinks the pulse to 5 millimeters. When complexes are too small to measure, double standard gain enlarges the pulse to 20 millimeters. Recognizing these variants prevents misreading the tracing entirely. Every EKG interpretation depends on trustworthy axes. A quick check of the calibration pulse, 10 millimeters tall, 0.2 of a second wide, confirms the machine is set correctly and the diagnostic reading can begin with confidence. Question 8. A patient calls and asks why the practice will not disclose her sister's account information. Which of the following HIPAA principles best supports the practice's response? Your options are A. Records are public information. B. Anyone may view any chart. C. Family members always have access. D. Minimum necessary access. Got a guess? Lock it in. The correct answer is D. Minimum necessary access. D is correct because the HIPAA minimum necessary rule limits disclosure of protected health information to authorized purposes only. Without a signed authorization for release of information, the practice cannot share account details with relatives, regardless of family relationship to the patient. Is wrong because health records are not public information at any time. HIPAA restricts disclosure to authorized purposes, and even within the practice, access is limited to staff with a legitimate need to access the record for treatment, payment, or operations. B is wrong because allowing anyone to view any chart violates HIPAA standards entirely. Audit trails detect unauthorized access, and snooping is grounds for termination and federal fines for individuals involved with unauthorized access to protected health information at all. C is wrong because family access requires the patient authorization or a legal representative role such as a power of attorney. Adult family members do not automatically have rights to view or receive another adult medical information without authorization documents on file. HIPAA's privacy rule doesn't just say who can receive health information, it also limits how much information can be shared. That limiting principle is called the minimum necessary standard, and it runs through every disclosure decision a covered entity makes. Medical records are uniquely sensitive because one chart can reveal mental health history, substance use, genetic risk, reproductive choices, and financial details. Casual disclosure can damage employment, insurance status, family relationships, and personal dignity, which is exactly why scope of disclosure matters even when a disclosure is technically permitted. The minimum necessary rule operates through 4 concrete mechanisms: role-based access in the EHR, audit trays that log every chart view, signed authorizations for release of information, and front desk verification of identity and relationship. None of these relies on good faith alone. Each is documented and reviewable. A critical exam concept is the gap between social expectation and legal authority. Being a spouse, parent, sibling, or adult child does not grant automatic chart access. Adult patients hold their own privacy rights, and family access requires a signed authorization, a healthcare power of attorney, or legal guardianship. When a STEM describes a family member requesting information without a signed release, the answer is always no disclosure. The minimum necessary rule means only the right information goes to the right person, and only when documented permission exists. Question 9. A patient is scheduled for a flexible sigmoidoscopy. Which of the following positions is most appropriate for the medical assistant to place the patient in? Your options are A. Knee chest, B. Sims, C. lithotomy, D. Trendelenburg. Which one is it? Pause the video if you need more time. The correct answer is A, knee chest. A is correct because knee chest position straightens the rectosigmoid angle and provides the best exposure for flexible sigmoidoscopy. Sims position can serve as an alternative when knee chest is not tolerated, but knee chest remains the procedure-aligned standard for the lower colon. B is wrong because Sims position is appropriate for rectal exams and enemas and is sometimes used when knee chest is not tolerated, but it is not the procedure-aligned first choice for sigmoidoscopy generally. C is wrong because lithotomy is used for pelvic, obstetric, and lower urologic procedures, not for examining the lower colon through a sigmoidoscope inserted via the rectum during the office procedure scheduled today. D is wrong because Trendelenburg lowers the head for shock or lower abdominal surgery and would not provide useful access during sigmoidoscopy, where access is from the perineum through the anus into the lower colon. Patient positioning is more than comfort. It aligns the body's geometry with the clinical task. For lower colon procedures like sigmoidoscopy, the right position can mean the difference between a smooth exam and an incomplete one. The lower colon forms a series of natural curves. In knee-chest position, knees flexed, hips elevated, chest flat against the table. Gravity shifts abdominal contents upward and straightens the rectosigmoid angle, letting the scope advance more easily and improving visualization of the mucosa. 4 positions dominate lower body procedures. Knee chest is the first choice for sigmoidoscopy. Sims, left lateral with right knee flexed, is the backup when knee chest can't be tolerated. Lithotomy opens the perineum for pelvic and urologic work. Trendelenburg tilts the head down for lower abdominal surgical access. Exam questions often pit knee chest against Sims for sigmoidoscopy. Knee chest wins because it straightens the rectosigmoid angle most completely. Sims is reserved for patients who cannot tolerate knee chest due to age, joint disease, obesity, or pulmonary status. Knowing the why prevents choosing the backup when the question calls for the primary position. When you see sigmoidoscopy or proctoscopy on an exam, think knee chest first, Sims second. When you see pelvic or obstetric, think lithotomy. Memorizing the indication behind each position, not just the name, is what produces the right answer when the stem changes the procedure. Question 10. Which of the following statements most accurately describes the difference between capacity and competency? Your options are A. Capacity and competency are identical legal terms. B. Capacity is clinical and competency is legal. C. Capacity is legal and competency is clinical. D. Both are determined by a court hearing. Take a second. Which answer would you pick? The correct answer is B. Capacity is clinical and competency is legal. B is correct because capacity is a clinical judgment that the patient can understand and decide for a specific decision and may fluctuate, while competency is a legal determination made by a court with broader implications. A is wrong because capacity and competency are distinct concepts. Capacity is a fluctuating clinical assessment for a specific decision, while competency is a legal designation from the court regarding overall decision-making authority of the patient today. C is wrong because capacity is the clinical concept and competency is the legal one, so reversing them inaccurately describes the difference and may lead to confusion about who determines decisional ability for a particular decision today. D is wrong because only competency is determined by a court, while capacity is assessed clinically by the provider for each specific decision and may change over time depending on the patient's condition and circumstances today. 2 terms that sound interchangeable can cause serious errors in medical practice and legal documentation. Understanding their precise distinction is essential for consent. surrogate decision-making, and patient autonomy. Capacity is assessed by a healthcare provider for one specific decision at one specific moment. It can fluctuate. Competency is a formal court determination that a person cannot manage their personal, medical, or financial affairs and requires a guardian or conservator. Providers assess capacity through conversation using 4 elements. The patient must understand the information, appreciate how it applies to them, reason through the choice using their own values, and communicate a stable decision. Meeting all 4 grants capacity for that decision, regardless of any underlying diagnosis. A patient with early dementia may demonstrate full capacity to consent to a routine cataract surgery this morning, while a court-appointed guardian handles their financial affairs. The clinical assessment stands on its own. No court order is needed when the question is purely clinical. On exam day, when a STEM describes a provider assessing whether a patient can consent to a specific treatment, the answer is capacity. When you see a court, a guardian, or a conservator, the answer is competency. Never collapse these 2 into one. Question 11. A medical assistant receives a subpoena requesting a patient's records. Which of the following actions should the medical assistant take first? Your options are: A. Send the records that same business day. B. Refuse without contacting risk management today. C. Notify the privacy officer or risk management. D. Call the patient's attorney for guidance directly. Before I reveal it, which one do you think is right? The correct answer is C. Notify the privacy officer or risk management. C is correct because a subpoena alone may not satisfy HIPAA disclosure requirements, so the medical assistant should notify the privacy officer or risk management to verify whether a court order, authorization, or satisfactory assurances accompany the request. A is wrong because sending records the same day without verifying the form of legal process risks an improper disclosure under HIPAA, which requires either a court order, written authorization, or satisfactory assurances accompanying the subpoena currently received. B is wrong because refusing without contacting risk management may itself violate legal process if the request is valid. The appropriate first step is to involve the privacy officer or risk management who can review the request properly. D is wrong because calling the patient's attorney for guidance is not the first action, since the practice's privacy officer or risk management is responsible for evaluating subpoenas and ensuring HIPAA-compliant responses to such legal requests today. Receiving a subpoena does not automatically authorize your practice to release protected health information. HIPAA treats the legal command and the disclosure decision as 2 completely separate questions, each governed by its own rules. Subpoenas come from very different sources and each carries a different legal weight under 45 CFR 164 FVDF. A court order signed by a judge is the strongest form, while an attorney-issued subpoena duces TECUM is considerably weaker. Confusing these categories is one of the most common compliance failures in primary care. Before any chart leaves the office, one of 3 things must be present: a court order signed by a judge, a written HIPAA-compliant authorization from the patient, or satisfactory assurances showing the patient was notified and given time to object, or that a qualified protective order was sought. When a subpoena arrives, the medical assistant does not evaluate its legal sufficiency or contact the requesting attorney. The first action is always internal escalation. Timestamp the document, secure it, and route it to the privacy officer or risk management that same business day. Whenever an exam STEM mentions a subpoena or attorney records request, the correct first action is escalation to the privacy officer, never sending records immediately, calling the attorney for guidance, or refusing without review. Subpoenas are neither routine releases nor mandated reports, which is exactly why they require a specialist review. Question 12. Which epidemiologic term describes the number of new cases of a disease occurring in a population during a specified period? Your options are A. Prevalence, B. Endemic level, C. Mortality rate, D. Incidence. What's your answer? Commit to one before I continue. The correct answer is D. Incidence. D is correct because incidence describes the number of new cases of a disease during a defined period in a population. It contrasts with prevalence, which counts all existing cases at one point in time across the population. A is wrong because prevalence counts all existing cases of a disease at a single point in time, so it does not describe the new cases occurring during a defined time period in the community as described. B is wrong because endemic level describes the baseline ongoing presence of a disease in a population, so it does not describe the new cases reported during a defined time period in the local community in this scenario. C is wrong because mortality rate describes the death rate from a disease in a population, so it does not describe the count of new cases reported during a defined period in the community here. Incidence and prevalence are two of the most tested measurements in epidemiology, and they answer fundamentally different questions. Understanding what each one counts thus and when is the key to telling them apart. Incidence captures the rate at which healthy people become sick. The numerator is always new diagnoses. The denominator is always the at-risk group and a specific time window, such as a flu season or a calendar year, must be defined. Think of a bathtub. Incidence is the rate of water flowing in, new cases arriving over time. Prevalence is the water level at a single moment, reflecting everyone currently in the disease state, including long-standing chronic cases. A short-lived illness like influenza can have high incidence during a season, but low prevalence at any single moment because patients recover quickly. A chronic condition like type 2 diabetes can have low incidence but high prevalence because patients live with it for decades. When you see signal words like new cases during a specified period or population at risk, think incidence. When you see total, currently affected, or at one point in time, think prevalence. Keeping these definitions sharp prevents misleading conclusions about whether an intervention is actually working. Question 13. A patient with terminal illness says she will eat well and pray daily so she might beat the disease. Which of the following stages of grief does this statement reflect? Your options are A. Denial, B. Acceptance, C. Bargaining, D. Depression. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Bargaining. C is correct because bargaining involves negotiating, often silently, to delay or change an outcome through promises or lifestyle changes. Statements about lifestyle reform or pleas for more time reflect this stage in the Kubler-Ross 5-stage model of grief. A is wrong because denial rejects the diagnosis entirely as untrue rather than offering trade-offs to alter the outcome, so it does not match the patient's active negotiation about diet and prayer in the statement made during the visit today. B is wrong because acceptance reflects peace and planning for what comes next at the end of life, which contradicts the active negotiation and hope for cure, expressed in the patient's statement about diet and prayer at this visit today. D is wrong because depression features sadness, withdrawal, and low energy rather than the active negotiation expressed in the scenario. So the patient's verbal effort to change the outcome through lifestyle changes does not align with the depression stage. Bargaining is the third stage in the Kubler-Ross model of grief. It emerges when a person facing loss attempts to negotiate their way out of the situation, often with a higher power or the universe itself. Kubler-Ross developed this framework in the 1960s after interviewing dying patients, identifying 5 recognizable emotional stages: denial, anger, bargaining, depression, and acceptance. Importantly, these stages are not strictly linear. Patients may skip, revisit, or cycle through them. Bargaining has a specific structure. The patient offers a behavior change in exchange for a better outcome. It often sounds positive, promises to eat well, pray daily, or attend every appointment, which is why it can be confused with acceptance. The defining signal is always the conditional trade. On exam day, watch for signal words. Denial flatly rejects reality. Depression brings tearfulness and withdrawal. Acceptance sounds reconciled with end-of-life planning rather than pleading. Bargaining is the stage with the transaction, a promise made in hopes of changing the outcome. When a patient sounds optimistic but ties every positive change to a hoped-for outcome, that is bargaining, not acceptance. Recognizing this helps clinicians validate the patient's effort without reinforcing false expectations. Question 14. A clinic discovers vaccines may have been compromised after an overnight power loss. Which of the following actions should the medical assistant take? Your options are: A. Use the vaccines anyway. B. Discard them without recording. C. Hide the incident from leadership. D. Quarantine and contact manufacturer guidance. Which would you go with? Lock it in before the reveal. The correct answer is D. Quarantine and contact manufacturer guidance. D is correct because compromised vaccines should be quarantined with a do not use label, and the manufacturer or state immunization program contacted for guidance on viability. Documentation of the incident and corrective actions is required for compliance with CDC vaccine storage protocols. A is wrong because using potentially compromised vaccines risks giving an ineffective product to patients. The patient may believe they are protected when in fact the vaccine lost potency during the temperature excursion overnight, which violates CDC vaccine storage guidance. B is wrong because discarding the vaccines without documentation hides the incident and prevents accountability later. Logs and reports are required for vaccine accountability and for state immunization program oversight of practices that participate in publicly funded vaccine supply programs and reporting. C is wrong because hiding incidents from leadership exposes the practice to greater risk under compliance and immunization program rules. Compliance programs require open reporting and corrective action rather than concealment of vaccine safety events from leadership, the manufacturer, or state programs. The cold chain is the structured system that keeps vaccines at the correct temperature from manufacturer to patient. When that chain breaks, potency can be silently lost, and the patient has no way to know. Refrigerated vaccines must stay between 36 and 46 degrees Fahrenheit. A power outage, propped door, or malfunctioning compressor can compromise an entire inventory overnight without changing how the vials look. When an excursion is suspected, the affected vials are immediately separated and marked do not use. The event is documented and reported to the manufacturer, the Vaccines for Children coordinator, or the state immunization program, who use stability data to determine whether the product can still be used. The exam tests whether you recognize dangerous shortcuts, using vaccines that look fine, discarding quietly, or hiding the incident all violate CDC storage and handling standards, and can block insurance recovery or replacement shipments. Remember, cold chain failure is a product integrity problem, not an adverse event report. The correct response always involves quarantining affected vials, contacting the right authority, and fully documenting the incident before any patient receives that stock. Question 15. Which lymphocyte type does HIV preferentially target and destroy as the infection progresses? Your options are A. B cells, B. CD4 helper T cells, C. neutrophils, D. eosinophils. Don't overthink it. Which one feels right? The correct answer is B. CD4 helper T cells. B is correct because HIV preferentially infects CD4 helper T cells, gradually depleting them over time. As the count falls, cell-mediated immunity weakens, leaving the patient vulnerable to opportunistic infections that define progression to acquired immunodeficiency syndrome. A is wrong because B cells produce antibodies and form humoral immunity, so although they are part of the adaptive system, they are not the primary cells that HIV targets and depletes during chronic infection over time. C is wrong because neutrophils are phagocytic granulocytes that fight bacterial infections through innate immunity, so they are not the lymphocytes that HIV preferentially infects and destroys to weaken the adaptive immune system. D is wrong because eosinophils are granulocytes involved in allergic responses and parasite defense, so they are not the lymphocytes that HIV preferentially infects and destroys during the progression of chronic disease over time. HIV is a retrovirus with a very specific target inside the adaptive immune system, the CD4 helper T cell. Understanding why these cells are targeted and what happens when they're lost is the foundation of HIV pathology. HIV gains entry using the CD4 surface molecule as a lock with a core receptor, either CCR5 or CXCR4. As a second key, this precise molecular fit is exactly why CD4 helper T cells are the primary target, not other lymphocytes like CD8 cells or B cells. CD4 helper T cells coordinate the entire adaptive immune response. They activate B cells, cytotoxic T cells, and macrophages through cytokine signaling. When HIV destroys these cells, the immune system loses its conductor, and the rest of the response collapses. Without treatment, CD4 counts fall roughly 50 to 100 cells per microliter each year. Once the count drops below 200, the diagnosis shifts to AIDS, and opportunistic infections like pneumocystis, jirovecii pneumonia, and CMV retinitis become life-threatening threats. On exam day, the key is precision. The target is specifically CD4 helper T cells, not CD8 cytotoxic T cells, not B cells, not neutrophils. Antiretroviral therapy is monitored with CD4 counts and viral load, both anchored to this one specific cell. Question 16. A medical assistant is cleaning an exam room between patients. Which of the following sequence best follows infection prevention principles? Your options are A. Mop floors first, then disinfect surfaces. B. Wipe the dirtiest area first to save time. C. Trash, dust high to low, surfaces, then mop. D. Spray air freshener and replace paper. Got a guess? Lock it in. The correct answer is C. Trash, dust high to low, surfaces, then mop. C is correct because standard turnover proceeds clean to dirty and top to bottom. Trash is removed first, dust falls high to low, touch surfaces are disinfected, and floors are mopped last, so falling debris does not contaminate cleaned surfaces. A is wrong because mopping first defeats the top to bottom rule because dust and dirt from higher surfaces will fall onto a freshly cleaned floor during the rest of the turnover process for that exam room afterward. B is wrong because starting with the dirtiest surface contaminates supplies and gloves and spreads pathogens onto cleaner surfaces during the rest of cleaning, working against the clean to dirty principle of infection control today. D is wrong because air freshener and paper replacement are incidental tasks that do not address microbial contamination on surfaces and the floor, which is the actual infection prevention goal of room turnover work overall. Exam room turnover is the structured sequence of cleaning and disinfection that prepares a shared space for the next patient. The order isn't arbitrary. It's built on two directional principles that keep gravity and workflow working for you, not against you. Every step in the sequence follows two rules: clean before dirty and top before bottom. Dust and debris fall downward, so working against gravity means recontaminating surfaces you've already cleaned. These principles prevent that from happening. The standard sequence begins with trash and used linens. Removing them first prevents contamination spreading over cleaned areas. Dusting follows from high surfaces like shelves and light covers down to counters. High-touch surfaces are then disinfected, and floors are mopped last to capture anything dropped during prior steps. High-touch surfaces: the exam table, blood pressure cuff, door knob, keyboard, and chair arms must be treated with an EPA-registered disinfectant and allowed to sit for the full contact time printed on the label, typically 2 to 10 minutes. Wiping and immediately retouching a surface means no disinfection has actually occurred. Exam questions test the sequence, not the product. Any answer that starts with mopping, targets the dirtiest spot first, or skips contact time violates the directional logic of infection prevention. When in doubt, follow gravity and keep the clean path clean. Question 17. A patient using a Spanish language interpreter looks confused after receiving medication instructions. Which of the following techniques best confirms that the patient understood the instructions? Your options are: A. Use the teach-back method. B. Ask yes or no questions only. C. Repeat the instructions louder. D. Hand over a written sheet. Which one is it? Pause the video if you need more time. The correct answer is A. Use the teach-back method. A is correct because the teach-back method asks the patient to explain in their own words what they will do, which reveals misunderstandings far more reliably than yes or no questions or written handouts alone across language gaps. B is wrong because patients often answer yes to confirm understanding even when confused. So closed yes or no questions are unreliable for verifying medication comprehension when crossing language and literacy barriers in clinic encounters today. C is wrong because volume does not improve comprehension across language barriers, may feel disrespectful, and ignores the underlying interpretation and literacy concerns that should be addressed through the trained medical interpreter during the encounter. D is wrong because written handouts help only if the patient can read that language at the right level and do not by themselves confirm true comprehension of the medication regimen during this current office encounter today. The teach-back method is a communication technique designed to confirm that patients truly understand their care instructions. Not just that they said yes when asked. Instead of a simple comprehension question, the clinician hands the explanation back to the patient and listens carefully for accuracy. Health literacy research shows that roughly 1/3 of adults struggle to understand standard health information. Even educated patients miss instructions under clinical stress. Yes or no comprehension checks catch almost none of these gaps, while teach-back catches most of them in under 2 minutes. The technique follows 3 steps. First, the clinician explains new information using plain language, one concept at a time. Second, they ask an open-ended question framed as a personal favor, not a quiz. Third, they listen for accuracy, correct gently if needed, and repeat the cycle if the patient missed something. Imagine a patient who just learned a new medication regimen. She tells the medical assistant she will take it twice a day with food, but the order is 3 times a day on an empty stomach. The assistant catches the error before she leaves, preventing a potentially serious dosing mistake. The most important nuance is framing. When teach-back reveals a gap, it signals the clinician's explanation was unclear. Not that the patient failed. The burden of clarity always rests on the clinician. making teach back a partnership, not a test. Question 18. Which of the following abbreviations appears on the Joint Commission Do Not Use list? Your options are A. EMAG, B. EMOIR, C. U, D. MC. Take a second. Which answer would you pick? The correct answer is C. U. C is correct because the Joint Commission Do Not Use list bans the abbreviation U for unit because it can be mistaken for 0, 4, or CC when handwritten. Orders should spell out the word unit completely to prevent insulin dosing errors. A is wrong because the abbreviation mg for milligram is acceptable on orders and is not on the Joint Commission Do Not Use list, since it is a standard metric abbreviation used safely throughout pharmacy and clinical documentation across healthcare settings. B is wrong because the abbreviation ml for milliliter is the preferred volume notation and is not on the Joint Commission Do Not Use list, replacing the older CC abbreviation that was flagged as a potential source of dosing confusion. D is wrong because the abbreviation mcg for microgram is the preferred replacement for the older Greek letter abbreviation and is not on the Joint Commission Do Not Use list, since it is unambiguous in handwritten and printed orders. The Joint Commission Do Not Use list is a formally mandated catalogue of abbreviations banned from medical orders and clinical documentation. It exists because ambiguous handwritten notation has caused fatal dosing errors, i.e., a single misread character leading a patient to receive 10 times the intended dose. Each banned item has a safe replacement spelled out in full. U becomes the word unit. IU becomes international unit since IU was misread as 10. QD and QOD are replaced by daily and every other day because both were confused with QID, 4 times a day. MES, MESO4 and MgSO4 are spelled out entirely to prevent fatal mix-ups between morphine sulfate and magnesium sulfate. Consider a classic sentinel event. A paper insulin order reads 4U at bedtime. A nurse misreads U as a 0 and prepares 40 units. The patient develops severe hypoglycemia overnight. This real pattern of harm is exactly why U is the most heavily tested item on the Do Not Use list. A key exam nuance is knowing which abbreviations are banned versus merely discouraged. The official list is short and specific. The volume abbreviation ml, the mass abbreviations MOG and MAC are not banned. They are preferred replacements. Knowing this boundary is the heart of what exam writers test. When reviewing orders or documentation, the rule is simple. If it is on the Do Not Use list, spell it out completely. The abbreviation U alone has caused more documented patient harm than almost any other symbol in clinical writing. Question 19. A medical assistant documents a rash on the front of the chest near the breastbone. Which of the following directional terms describes this location? Your options are A. Posterior, B. Distal, C. Lateral, D. Anterior. Before I reveal it, which one do you think is right? The correct answer is D. Anterior. D is correct because anterior, also known as ventral, refers to the front of the body and includes the chest, abdomen, and shins. Posterior or dorsal is the back, while distal and lateral describe distance and midline relationships. A is wrong because posterior points to the back of the body rather than the chest where the rash is located, so it would mislocate the lesion in the chart and confuse anyone reviewing the documentation later for follow-up care. B is wrong because distal describes distance from a point of attachment rather than a front to back orientation, so it cannot place the rash on the chest and would be inappropriate for describing trunk surface anatomy at the location described. C is wrong because lateral indicates direction away from the midline rather than the front of the body, so it cannot specify whether a structure sits on the front or back of the chest at the lesion site described. Anatomical directional terms give clinicians a precise, shared vocabulary for describing exactly where something is on the body. This system is built around a single reference point called the anatomical position. The anatomical position, standing upright, facing forward, palms forward, is the universal reference from which every directional term is defined. Anterior means front, posterior means back, superior toward the head, inferior toward the feet, medial toward the midline, and lateral away from it. These 6 terms form 3 paired axes. Anterior and posterior describe front versus back. Superior and inferior describe head versus feet. Medial and lateral describe distance from the body's midline. 2 additional pairs, proximal versus distal along a limb, and superficial versus deep from the surface, complete the core set. The most tested nuance is keeping axes separate. Proximal and distal describe distance along a limb from its trunk attachment. Medial and lateral describe distance from the midline. Superficial and deep describe distance from the surface. These axes sound similar but describe entirely different geometric relationships. When a chart reads erythematous patch on the anterior chest, any clinician anywhere immediately knows the lesion is on the front, at chest level, with no posterior involvement, no phone call needed. That precision is exactly why the standardized vocabulary exists. Question 20. A patient with congestive heart failure needs a diet that reduces sodium and emphasizes produce and low-fat dairy. Which of the following diets best fits this guidance? Your options are A. DASH diet, B. Mediterranean diet, C. Gluten-free diet, D. Bland diet. What's your answer? Commit to one before I continue. The correct answer is A. DASH diet. It is correct because DASH stands for Dietary Approaches to Stop Hypertension and emphasizes produce, whole grains, and low-fat dairy with reduced sodium. It lowers blood pressure and supports heart failure management through fluid balance and reduced cardiac workload. B is wrong because the Mediterranean diet emphasizes olive oil, fish, legumes, and moderate wine and is heart healthy overall, but it does not specifically focus on low sodium for fluid management in heart failure, the way DASH does for these patients. C is wrong because a gluten-free diet excludes wheat, barley, and rye for celiac disease and does not directly target sodium and produce balance, so it would not address the symptoms of fluid overload and high blood pressure in heart failure patients. D is wrong because a bland diet avoids spicy and acidic foods for ulcer or GERD management rather than addressing sodium and heart failure concerns, so it would not help with the leg swelling and shortness of breath the patient now reports. The DASH diet, Dietary Approaches to Stop Hypertension, is an evidence-based eating pattern designed specifically to lower blood pressure. It was developed through National Heart, Lung, and Blood Institute research and remains one of the most clinically validated dietary interventions available. The pattern prioritizes produce, whole grains, low-fat dairy, and legumes while restricting sodium, saturated fat, and added sugars. Sodium is typically targeted between 1,500 and 2,300 milligrams per day, which directly reduces fluid retention and cardiovascular strain. The diet works through multiple pathways simultaneously. Potassium counterbalances sodium at the cellular level. Calcium and magnesium promote smooth muscle relaxation in vessel walls. Reduced sodium lowers fluid volume, and less saturated fat gradually reduces atherosclerotic buildup over time. Knowing which diet matches which condition is what exam writers test. DASH is the answer when the STEM mentions high blood pressure or fluid overload with emphasis on produce and low-fat dairy. Mediterranean appears with olive oil and fish. Gluten-free signals celiac disease, and bland diet signals ulcer or reflux symptoms. When a question stem combines blood pressure management, sodium restriction, and a produce-heavy food pattern, dash is almost always the correct match. Recognizing these signal words quickly will make dietary counseling questions straightforward on exam day. Question 21. A woman of reproductive age is scheduled for a CT scan with contrast. Which of the following history elements is most important for the medical assistant to verify before the study? Your options are A. Last bowel movement and stool color. B. Recent caffeine and exercise habits. C. Last menstrual period and pregnancy status. D. Shoe size and standing height. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Last menstrual period and pregnancy status. C is correct because imaging with radiation or iodinated contrast can harm a developing fetus, so menstrual status and possible pregnancy must be confirmed before the study. The medical assistant documents the last menstrual period during routine imaging safety screening. A is wrong because bowel patterns are not relevant to imaging safety screening before a contrasted CT and would not change whether the study should be performed today, as the provider has ordered for the patient. B is wrong because caffeine and exercise affects vital signs in the moment, but do not influence the radiation or fetal safety screening that must be cleared before imaging with iodinated contrast in any patient. D is wrong because shoe size and height are baseline measurements but have no bearing on pregnancy screening that is required before imaging with iodinated contrast or significant ionizing radiation in any patient. Subcutaneous insulin injection delivers a measured dose into the fat layer between skin and muscle. Understanding the anatomy behind this route explains why site selection and technique matters so much clinically. The subcutaneous space sits just beneath the dermis and is rich in small capillaries, but poor in large blood vessels. This architecture produces a slow, predictable absorption profile, exactly what long-acting and intermediate-acting insulins require. 4 body regions carry enough adipose tissue in most adults to support reliable subcutaneous deposits: the abdomen, the back of the upper arm, the front of the thigh, and the upper outer buttock. The abdomen is preferred because of consistent depth and easy access. On the abdomen, a 2-inch zone around the umbilicus must be avoided because periumbilical tissue is fibrous and absorbs erratically. Rotating sites across the lower abdomen prevents lipohypertrophy, or retake, the lumpy, thickened tissue that forms from repeated injections in one spot and distorts absorption further. Confusing injection routes is a common exam trap. Intramuscular technique uses a longer needle and dense vasculature that pulls insulin in too quickly, raising hypoglycemia risk. Intradermal technique at a shallow angle is reserved for tuberculin and allergy testing, never for insulin. Question 22. A medical assistant prepares a controlled substance order for the office. Which of the following forms is required to order, schedule, and annotate list 2 medications from a wholesale supplier? Your options are A. FDA MedWatch form, B. Joint Commission audit form, C. DA Form 41, D. DA Form 222. Which would you go with? Lock it in before the reveal. The correct answer is D. DEA Form 22. D is correct because DEA Form 222 is the federal form used to order Schedule 2 controlled substances from a wholesale supplier. It tracks chain of custody to prevent diversion and is part of strict record keeping for DEA registrants. A is wrong because the FDA MedWatch form is a voluntary adverse event reporting tool for clinicians and patients, unrelated to ordering controlled substances from suppliers, and is used for post-market safety surveillance rather than supply chain control of medications. B is wrong because A, Joint Commission Audit Form, is a generic accreditation document associated with hospital and clinic surveys, which is unrelated to federal controlled substance ordering and tracking under the DEA registration requirements that apply to office practices. C is wrong because DEA Form 4.1 is the destruction form used when controlled substances are disposed of through reverse distribution, not when they are ordered from a wholesaler for office stock during routine restocking and inventory activities. Vaccine cold chain management ensures every dose reaches the patient with full potency intact. The principle is simple. Immunizing agents must stay within a validated temperature range from the moment they leave the manufacturer until the moment of injection. Most vaccines must be kept between 36 and 46 degrees Fahrenheit, or 2 to 8 degrees Celsius. A small subset, like varicella and certain mRNA products, have their own freezer or ultra-cold requirements. Outside these ranges, protein antigens and live attenuated viruses lose the potency that protects patients. The storage unit itself is purpose-built. A pharmaceutical-grade refrigerator holds a digital data logger that records temperatures continuously, and a glycol-filled bottle with a thermometer probe that mimics the thermal mass of the vaccines themselves. The door must seal tightly, and the unit cannot be shared with food, breast milk, or laboratory specimens. Staff document minimum and maximum temperatures at the start of every clinic day. Daily, not weekly. A daily check catches a refrigerator that drifted overnight before any patient receives a compromised dose, when readings fall outside range. Affected stock is immediately moved to a quarantine bin labeled Do Not Use until the manufacturer or state immunization program confirms viability. The CDC, vaccine manufacturers, and the Vaccines for Children program all align on daily temperature documentation. Cold chain failure is invisible to the patient. They walk out believing they are protected. Rigorous daily monitoring is the only way to guarantee every dose delivered is a dose that actually works. Question 23. A patient calls the clinic reporting crushing chest pain radiating to the left arm with sweating. What should the medical assistant do next? Your options are: A. Schedule a routine appointment. B. Send a portal message later. C. Direct the caller to call 911. D. Offer telehealth tomorrow afternoon. Don't overthink it. Which one feels right? The correct answer is C. Direct the caller to call 911. C is correct because chest pain with classic cardiac features requires immediate emergency response. Telephone triage protocols direct the medical assistant to instruct the caller to call 911 without delay or further conversational triage about additional symptoms or history. A is wrong because routine scheduling delays evaluation of a possible heart attack. Time-sensitive cardiac events require emergency department evaluation rather than an appointment slot in the regular clinic schedule that may be hours or days away from the call. B is wrong because portal messaging is asynchronous and may not be read for hours by the clinical team. A possible heart attack must be addressed immediately through emergency medical services rather than through a delayed electronic communication channel inside the portal. D is wrong because a telehealth appointment cannot deliver emergency cardiac care. Tomorrow is too late for a suspected acute coronary event needing immediate hospital evaluation, electrocardiogram, troponin testing, and treatment with potential reperfusion therapy without delay today. The teach-back method is a structured technique where clinicians ask patients to demonstrate understanding in their own words. Not simply confirm it. This matters because patient self-report of comprehension often doesn't reflect what they'll actually do at home. Health literacy gaps are widespread, often invisible and dangerous. Patients frequently say they understand while missing critical details, and nothing in a typical visit catches the difference before they walk out the door. The clinician invites the patient to show or explain the steps. Any gaps surface immediately during the demonstration. The clinician then reteaches only what was missed, checks again, and documents the encounter. For insulin specifically, teach-back must verify each concrete, observable step, from site selection and injection angle to pen storage and recognizing low blood sugar. Because each mistake carries immediate consequences, every step needs demonstrated confirmation, not just a verbal yes. Teach-back is the only approach that produces real evidence of comprehension. Asking for questions invites a polite no, a written quiz test reading not skill. And documenting understanding without observation creates a liability risk if harm follows. Question 24. A medical assistant suspects a child is being abused. Which of the following actions should the medical assistant take first? Your options are: A. Confront the parent in the exam room. B. Wait for confirmation of the suspected abuse. C. Document and dismiss the patient quickly. D. Ensure safety and report to authorities. Got a guess? Lock it in. The correct answer is D. Ensure safety and report to authorities. D is correct because mandatory reporters must ensure the patient's immediate safety, notify the provider and supervisor, and report suspected child abuse to the appropriate agency, such as Child Protective Services, in good faith, based on reasonable suspicion. A is wrong because confronting the parent in the exam room may compromise the child's safety, escalate the situation, and is not the medical assistant's role. The agency conducts the formal investigation after a report is filed. B is wrong because waiting for confirmation is incorrect because mandatory reporting laws require reports based on reasonable suspicion rather than confirmed abuse, with the agency rather than the medical assistant determining whether the abuse occurred today. C is wrong because documenting and dismissing without reporting violates mandatory reporting laws, may result in criminal liability for the medical assistant, and leaves a vulnerable child at risk of continued harm and unaddressed neglect today. Community-acquired pneumonia, or CAP, is a lung parenchyma infection that develops outside hospitals or long-term care facilities. Understanding its most likely cause shapes everything from empiric antibiotic choice to vaccination counseling. Streptococcus pneumonia, the pneumococcus, is a gram-positive lancet-shaped diplococcus surrounded by a polysaccharide capsule that resists phagocytosis. After colonizing the upper airway, it aspirates into the alveoli, recruits neutrophils, and produces the classic lobar consolidation seen on chest X-ray. The classic presentation includes productive cough with rust-colored sputum, high fever with rigors, and pleuritic chest pain. Chest imaging confirms the diagnosis by showing a new lobar infiltrate consistent with consolidation. Exam questions contrast pneumococcus with three distractors. Mycobacterium tuberculosis causes chronic granulomatous disease with weeks of cough and night sweats. Escherichia coli is a urinary and abdominal pathogen. Helicobacter pylori drives peptic ulcer disease. None of these three cause typical outpatient pneumonia. The pneumococcal polysaccharide capsule is also the target of conjugate and polysaccharide vaccines, recommended at age 65 and earlier for high-risk patients. Accurate vital signs, oxygen saturation, and comorbidity history collected by the medical assistant directly support triage and treatment decisions. Question 25. A patient with cirrhosis has falling albumin and clotting factors. Which organ normally produces these plasma proteins? Your options are A. Spleen, B. Kidney, C. Liver, D. Pancreas. Which one is it? Pause the video if you need more time. The correct answer is C. Liver. C is correct because the liver synthesizes plasma proteins including albumin and most clotting factors, detoxifies drugs and ammonia, processes bilirubin, and stores nutrients. Cirrhosis impairs these functions, producing low albumin and bleeding tendencies in patients. A is wrong because spleen filters blood and supports immune surveillance, so it does not produce the plasma proteins and clotting factors that decrease in cirrhosis when liver function declines progressively over time in patients. B is wrong because kidney filters blood and produces urine while regulating fluid and electrolyte balance, so it does not synthesize plasma proteins and clotting factors that fall in the cirrhotic patient described in this question. D is wrong because pancreas produces digestive enzymes and insulin and glucagon hormones, so it does not synthesize the plasma proteins and clotting factors that decline in patients with chronic liver disease and cirrhosis. Intramuscular injection delivers medication directly into skeletal muscle, where rich blood supply allows faster absorption than subcutaneous routes. For infants and young children, the vastus lateralis, on the lateral thigh, is the standard site, chosen specifically because its muscle bulk is well developed even before a child can walk. The injection target is found by dividing the distance from the greater trochanter to the lateral femoral condyle in 2/3. The middle third, on the outer side of the thigh between the front and the side, is where the needle is inserted at 90 degrees straight into the muscle belly. The vastus lateralis is preferred for infants for 4 key reasons. The muscle is well developed at birth. It sits far from the sciatic nerve. The target area lacks large blood vessels, and the thigh is easy to hold still during the injection. Exam questions often contrast the vastus lateralis with 3 distractors. The dorsogluteal site is largely abandoned due to sciatic nerve proximity. The deltoid is reserved for older children and adults. The gastrocnemius on the back of the lower leg is never used for intramuscular injection. When you see an infant immunization scenario, the answer is the vastus lateralis, middle third of the lateral thigh, needle at 90 degrees. No aspiration needed for routine vaccines. Question 26. A patient with diabetes wears a cuff at home that transmits blood pressure readings to the clinic, where a nurse reviews them later. Which of the following telehealth modalities is being used? Your options are A. Synchronous video visit, B. Mobile health application, C. Patient portal messaging, D. Remote patient monitoring. Take a second. Which answer would you pick? The correct answer is D. Remote patient monitoring. D is correct because remote patient monitoring uses connected devices such as cuffs, glucometers, or scales that transmit data to the care team for asynchronous review. The data flow supports chronic disease management between in-person visits effectively. A is wrong because a synchronous video visit involves a live audio-visual encounter between patient and provider in real time, which does not match the device-based asynchronous data transmission described in the diabetes management scenario at home. B is wrong because a mobile health application typically refers to smartphone tools for medication reminders, symptom tracking, or education rather than the cuff-to-clinic data flow shown when a wearable device sends vital sign data automatically. C is wrong because patient portal messaging is secure two-way communication between patient and clinic through the portal, which is a separate function from device-based monitoring of vital signs collected through wearable equipment outside the office. Erythropoietin is the hormone that drives red blood cell production, and understanding where it comes from and what it targets is the key to connecting kidney disease with anemia. The kidneys, specifically peritubular fibroblasts in the renal cortex, detect low oxygen and respond by secreting erythropoietin. That hormone travels to the bone marrow and drives erythroprogenitor cells to survive, proliferate, and mature into red blood cells. Even with adequate erythropoietin, the bone marrow cannot produce healthy red blood cells without iron, vitamin B12, and folate. This is why treating anemia in chronic kidney disease pairs an erythropoiesis stimulating agent with iron supplementation. Exam questions contrast erythropoietin with 3 other hormones. Renin is released by juxtaglomerular cells and activates the RAS to raise blood pressure. Aldosterone comes from the adrenal cortex to retain sodium. Antidiuretic hormone comes from the posterior pituitary to retain water. Only erythropoietin is made by the kidney itself and targets the bone marrow. Chronic kidney disease destroys the cells that make erythropoietin, producing a normocytic normochromic anemia even when iron stores are normal. Recombinant erythropoietin and agents like darbepoetin alpha replace that lost signal, raising hemoglobin and relieving fatigue in dialysis patients. Question 25. A medical assistant is preparing a subcutaneous insulin injection for an adult patient. Which of the following sites is most appropriate? Your options are A. Abdomen at least 2 inches from umbilicus. B. Ventrogluteal site in the buttock. C. Deltoid muscle in the upper arm. D. Inner forearm at a shallow angle. Before I reveal it, which one do you think is right? The correct answer is A. Abdomen at least 2 inches from umbilicus. A is correct because insulin is given subcutaneously into the abdomen at least 2 inches from the umbilicus, the back of the upper arm, or the anterior thigh, using a short fine gauge needle at the appropriate angle for body habitus. B is wrong because ventrogluteal placement is for deep intramuscular injections such as Z-Track depot medications, not for subcutaneous insulin where absorption depends on adipose layer placement, not muscle depth or volume in tissue. C is wrong because deltoid intramuscular technique uses a longer needle at 90 degrees and is the wrong tissue layer for subcutaneous insulin, which would absorb unpredictably from a muscle injection given there in clinic. D is wrong because inner forearm with a shallow angle describes intradermal allergy or tuberculin technique, not subcutaneous insulin, which requires fat layer placement at a steeper angle for proper absorption every time. Before any outpatient procedure using sedation agents like propofol or midazolam, 2 requirements stand above all others as true safety protections, not just routine preparation steps. Sedation suppresses the airway reflexes that prevent aspiration, and its effects on judgment and coordination persist long after the procedure ends. Comfortable clothes and removing jewelry are routine. They do not protect against aspiration or unsafe driving. NPO, from the Latin nil per os, means nothing by mouth. A full stomach can regurgitate when the patient is positioned or when air is introduced into the colon. The standard window is 8 hours for solids and 2 hours for clear liquids. When airway reflexes are blunted by sedation, stomach contents that reflux upward can enter the trachea instead of being cleared. This is aspiration. The reason NPO status is a clinical safety rule, not a minor formality. Residual sedation impairs judgment, reaction time, and coordination for hours. Rideshare alone is insufficient. The patient must be released to a responsible adult who can monitor for delayed effects. The escort's name and contact number must be confirmed before the procedure begins. Question 28. A medical assistant unpacks vaccine vials labeled refrigerate. Which of the following storage practices is required for this medication refrigerator? Your options are A. Bright lighting at all times. B. Storage in a freezer below zero. C. Daily temperature monitoring. D. Open shelves without a door. What's your answer? Commit to one before I continue. The correct answer is C. Daily temperature monitoring. C is correct because refrigerated medications require daily temperature logs to confirm storage stays within manufacturer limits. Routine calibration and immediate action on temperature excursions protect drug efficacy and patient safety, so monitoring is a daily expectation in clinical practice. A is wrong because bright lighting contradicts the need to protect many drugs from light, which often requires amber bottles, foil overwrap, or low-light storage areas, especially for medications that are degraded by ultraviolet exposure during prolonged exposure over time. B is wrong because freezer storage below zero is required for some vaccines, such as varicella, but not for the routine refrigerator range of 36 to 46 degrees, described in the scenario for the unloaded shipment of medications today. D is wrong because open shelves without a door would expose drugs to inconsistent temperatures, dust, and accidental contamination, none of which meets refrigerated medication standards. And a door-secured refrigerator is essential for proper temperature control during medication storage. Medical records serve as both clinical tools and legal documents, so corrections must follow strict standards. The goal is never to hide a mistake, it's to preserve the original while making the correction fully traceable. In a paper chart, draw a single thin line through the incorrect text so the original stays legible. Then write the word error, the date and time, and your initials directly beside it. The correct information goes in the next available space. Every correction must meet 3 requirements. It must be visible, so the original can still be read. Attributable, meaning the corrector is identified and time-stamped, so reviewers know exactly when the fix was made. Methods like erasing, white-out, scribbling, overwriting, or tearing out pages are all prohibited. Each one obscures what was originally documented, suggesting concealment, which can trigger legal and regulatory scrutiny even if the motive was innocent. Electronic health records apply the same principle. Instead of deletion, the correct method uses an amendment or addendum function that preserves the original entry, adds the correction, and logs every change in an audit tray with user identity and timestamps. Question 29. A medical assistant is verifying that a newly diagnosed diabetic patient understands insulin injection instructions. Which of the following techniques best confirms patient comprehension? Your options are A. Hand the patient a written quiz. B. Ask the patient if they have questions. C. Document that the patient understood. D. Use the teach-back method. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Use the teach-back method. D is correct because teach-back asks the patient to explain instructions in their own words, confirming actual understanding. Nodding and saying yes does not prove comprehension, especially with low health literacy or new complex regimens such as insulin therapy. A is wrong because a written quiz can feel intimidating, may not match the patient's literacy level, and does not invite the conversational confirmation that teach-back provides during the educational encounter for medication, self-administration instruction in clinic. B is wrong because asking about questions often yields no response from patients who feel embarrassed or uncertain about new content. It does not confirm whether the actual instruction was understood and retained well enough for safe self-administration. C is wrong because simply documenting understanding without verification creates a chart entry that may not reflect reality. The teach-back method must be performed first to confirm comprehension before documentation of patient understanding is appropriate at all. Doffing is the structured removal of personal protective equipment after patient contact. The sequence is designed around one core principle. The outside of used PPE is the dirtiest part of the encounter, and the wrong removal order moves contamination onto your skin, clothing, or face. Each item has a specific protective role. Gloves contact every surface touched and are the most contaminated. Gowns block splashes and droplets. Goggles or face shields trap aerosolized particles. Masks and respirators protect the airway from droplet and airborne pathogens. The CDC recommended order is gloves first, then goggles or face shield, then gown, and finally the mask or respirator. Hand hygiene is performed between steps and always at the end. Gloves come off first because they are the most contaminated item on your body. Technique matters as much as order. The glove-in-glove method turns each glove inside out so the contaminated outer surface is never touched by bare skin. For the mask, only the straps or ear loops are handled, never the front, which is the most contaminated surface facing the patient. The mnemonic is simple: gloves, goggles, gown, mask, with hand hygiene threaded throughout. Any sequence that begins with the gown or mask, or leaves gloves on during face area work, defeats the entire purpose of the protective ensemble. Question 30. Which bacterial pathogen is the most common cause of community-acquired pneumonia in adults? Your options are A. Mycobacterium tuberculosis, B. Escherichia coli, C. Streptococcus pneumonia, D. Helicobacter pylori. Which would you go with? Lock it in before the reveal. The correct answer is C. Streptococcus pneumonia. C is correct because Streptococcus pneumonia is the most common bacterial cause of community-acquired pneumonia in adults. Vaccines targeting common serotypes help reduce disease and severity in older adults and patients with chronic conditions. A is wrong because Mycobacterium tuberculosis causes tuberculosis with night sweats, weight loss, and hemoptysis. So it is a chronic lung pathogen rather than the most common cause of typical community-acquired bacterial pneumonia in adults. B is wrong because Escherichia coli typically causes urinary tract infections and gastrointestinal disease. So it is not the most common cause of bacterial community-acquired pneumonia among adults treated in outpatient settings worldwide today. D is wrong because Helicobacter pylori causes peptic ulcer disease and chronic gastritis in the stomach lining, so it is not the most common cause of bacterial community-acquired pneumonia among adults presenting with cough and fever. Look-alike, sound-alike medication errors happen when two drugs with similar names get confused during prescribing, dispensing, or administration. These mix-ups are among the most common and most preventable causes of patient harm. Lamisil and Lamictal are a classic documented pair. Lamisil contains terbinafine, an antifungal for nail infections, while Lamictal contains lamotrigine, used for epilepsy and bipolar disorder. They share the first three letters, similar length, and overlapping consonants, a recipe for dangerous confusion. Prevention relies on four-layered defenses. Tall man lettering emphasizes the differing parts of the name in capitals. Separated storage keeps look-alike bottles off adjacent shelves. Indication checking confirms the drug matches the patient's diagnosis. And barcode scanning catches any errors that survive earlier steps. Several other documented pairs appear on high-risk lists. Toradol and tramadol confuse an NSAID with an opioid. Adderall and Inderall confuse a stimulant with a beta blocker. Celebrex and Celexa confuse an NSAID with an antidepressant. The antifungal versus anti-seizure description, however, points uniquely to Lamisil and Lamictal. No single check is enough. Read back on verbal orders, tall man lettering, physical separation, and barcode scanning together create the redundancy that catches errors before they reach the patient. Question 31. Which muscle along the lateral upper thigh is the standard intramuscular injection site for infants? Your options are A. Gluteus maximus, B. Gastrocnemius, C. Biceps femoris, D. Vastus lateralis. Don't overthink it. Which one feels right? The correct answer is D. Vastus lateralis. D is correct because the vastus lateralis lies along the lateral aspect of the thigh and is part of the quadriceps group. It is the preferred intramuscular injection site for infants and is also acceptable in adult patients. A is wrong because gluteus maximus is a buttock muscle and the dorsogluteal site has been largely abandoned for injections due to sciatic nerve concerns. So it is not the lateral thigh muscle described. B is wrong because gastrocnemius is a calf muscle on the posterior lower leg, so it is not located in the lateral upper thigh and is not used as a routine intramuscular injection site in clinical practice. C is wrong because biceps femoris is one of the hamstring muscles on the posterior thigh, so it is not the lateral surface quadriceps muscle used as the standard intramuscular injection landmark in infant care. The vastus lateralis is the go-to intramuscular injection site for infants, and understanding why requires knowing both its anatomy and what surrounds it. Let's look at the underlying principles that make this muscle a safe, reliable target across the lifespan. The lateral thigh is safe precisely because the major neurovascular structures are located elsewhere. The femoral artery, femoral vein, and femoral nerve run through the medial femoral triangle, while the sciatic nerve travels along the posterior thigh, leaving the lateral surface as a clear, nerve-free corridor for the needle. To find the injection zone, divide the lateral thigh into thirds between the greater trochanter above and the lateral femoral condyle below. The middle third is the target, thick enough for full deposition and safely away from bony landmarks at either end. The vastus lateralis is the standard site for any infant under 12 months, including all birth and early series immunizations. It remains an acceptable backup across the lifespan whenever the deltoid lacks sufficient bulk. Needle length is adjusted for patient size, shorter for infants, longer for adults with greater adipose thickness. On exam questions, whenever you see an infant under 1 year needing an intramuscular injection, vastus lateralis is almost always the answer. Watch for phrases like lateral upper thigh, infant IM site, or quadriceps group as your signal cues. Question 32. Which kidney hormone stimulates the bone marrow to produce more red blood cells in response to low oxygen? Your options are A. Erythropoietin, B. Renin, C. Aldosterone, D. Antidiuretic hormone. Got a guess? Lock it in. The correct answer is A. Erythropoietin. A is correct because the kidneys secrete erythropoietin in response to low oxygen tension. This hormone stimulates red bone marrow to produce more red blood cells, raising oxygen carrying capacity. Chronic kidney disease often causes anemia from low erythropoietin. B is wrong because renin is a kidney enzyme that activates the renin-angiotensin-aldosterone system to raise blood pressure and conserve sodium, so it does not directly stimulate red blood cell production in the bone marrow. C is wrong because aldosterone is an adrenal cortex hormone that increases sodium reabsorption and potassium excretion in the distal tubule, so it does not signal the bone marrow to increase red blood cell production. D is wrong because antidiuretic hormone from the posterior pituitary promotes water reabsorption in the collecting duct, so it does not signal the bone marrow to produce more red blood cells in response to low oxygen. Erythropoietin is a glycoprotein hormone produced by peritubular fibroblast-like cells in the renal cortex. Its sole job is to match red blood cell production to the body's oxygen needs. When oxygen tension in the blood falls, renal cells accumulate a transcription factor called hypoxia-inducible factor, which switches on the erythropoietin gene. The secreted hormone travels to the red bone marrow, where it binds erythroid progenitor cells and drives their maturation into circulating red blood cells. May I find a process completed in roughly 5 to 7 days. Erythropoietin secretion rises whenever peripheral oxygen delivery falls short. Common triggers include high altitude, chronic blood loss, cardiopulmonary disease, and intense exercise. The resulting boost in red cell mass restores tissue oxygenation, completing the feedback loop. When kidney parenchyma is destroyed by chronic kidney disease, EPO production fails. The marrow, lacking its hormonal signal, slows red cell output and hemoglobin drops. Dialysis patients are routinely treated with synthetic erythropoietin stimulating agents, such as epoetin alpha or darbepoetin alpha, to compensate. On exams, distinguish erythropoietin from 3 common confusables. Renin activates the renin-angiotensin-aldosterone system to raise blood pressure. Aldosterone acts on the distal nephron to retain sodium and excrete potassium. Antidiuretic hormone promotes water reabsorption at the collecting duct. None of these influence erythropoiesis, only EPO does. Question 33. A patient who lives alone is scheduled for a colonoscopy under sedation. Which of the following pre-procedure instructions is most important for the medical assistant to confirm? Your options are: A. Wear comfortable clothes and remove jewelry. B. Arrange a driver and follow NPO instructions. C. Eat a small breakfast for energy beforehand. D. Bring a list of insurance plans only. Which one is it? Pause the video if you need more time. The correct answer is B. Arrange a driver and follow NPO instructions. B is correct because sedation requires NPO status and a designated driver because the patient cannot legally drive home afterward. Driving restrictions extend through the rest of the day, making transportation arrangements essential when the patient lives alone and lacks routine support. A is wrong because comfortable clothes and removing jewelry are standard preparations, but they do not address sedation safety the way confirming a designated driver and ongoing NPO compliance do for this patient living alone. C is wrong because eating a small breakfast violates NPO status and risks aspiration during sedation, which is the opposite of safe pre-procedure instructions for any colonoscopy performed under monitored anesthesia care in the suite. D is wrong because an insurance list helps with billing, but does not protect the patient from sedation-related risks during or after the colonoscopy is performed under sedation in the procedure suite later this morning. Colonoscopy lets clinicians visualize the entire colon lining, biopsy suspicious tissue, and remove polyps. Because moderate or deep sedation is required, preparation addresses 2 distinct safety concerns: clear visualization and the lasting effects of sedation. Residual stool blocks the view and increases missed adenoma rates, forcing repeat procedures. Sedation independently causes amnesia and impaired coordination, which is why patients cannot drive, operate machinery, or sign legal documents for the rest of the day. The flexible scope enters through the rectum and advances through each segment of the colon. Sigmoid, descending, transverse, ascending, all the way to the cecum, allowing the clinician to inspect every centimeter of mucosal lining. Among all pre-procedure reminders, NPO compliance and confirmed transportation address direct sedation safety. Bowel prep solution and the clear liquid diet ensure visualization. Comfortable clothing and an insurance card are reasonable reminders but are not clinical safety priorities. On exam stems that combine sedation with a patient who lives alone, always prioritize fasting status and confirm transportation. A patient planning to use an anonymous rideshare may need rescheduling. Most endoscopy centers require a named adult who can receive discharge instructions in person. Question 34. A medical assistant accidentally entered a note in the wrong patient chart on paper. Which of the following is the correct way to make the correction? Your options are A. Single line, error, initials and date. B. Delete the entry completely. C. Overwrite with corrected text. D. Erase electronically without trace. Take a second. Which answer would you pick? The correct answer is A. Single line, error, initials and date. A is correct because errors are corrected with a single line through the original entry. The word error, the date, and initials clearly visible. The original entry remains visible. The audit trail logs both the entry and the correction in the chart. B is wrong because deleting entries removes information that the audit trail must preserve in the medical record. Even mistaken entries become part of the legal record and cannot simply be erased from the chart at any point during or after documentation. C is wrong because overwriting hides the original entry from later view. Standard correction procedures keep the original entry visible while clearly marking it as an error and adding the corrected information instead of obscuring the prior documented note. D is wrong because electronic health records log every keystroke through the audit trail as required by federal record integrity rules. Attempts to erase electronically without trace are not possible in compliance systems and would itself be a violation reportable to compliance. Medical records are legal documents, and how you fix a mistake matters just as much as catching it in the first place. Let's look at the standard for correcting both paper and electronic charts. On a paper chart, correcting an error requires 4 things. Draw a single line through the entry so the original text is still readable. Write the word error beside it. Record today's date and add your initials. The corrected information is then added as a new entry in chronological order. Never squeeze between existing lines. The forbidden methods: erasing, using whiteout, scribbling over, or deleting, all obscure the original content. That transforms an honest mistake into potential record falsification, which regulators and courts treat as fraud or evidence destruction. Electronic health records work differently. The system itself preserves every change. Instead of crossing anything out, the user enters an addendum or amendment. The original time-stamped entry stays visible alongside the correction, and the access log captures every interaction for any future reviewer. Whether on paper or in an EHR, the principle is the same. The original entry must always remain visible. Transparency protects the patient, the provider, and the integrity of the entire record. Question 35. A medical assistant is doffing PPE after a contact precautions visit. Which of the following sequences is most appropriate? Your options are A. Mask, gown, gloves, goggles. B. Gown, gloves, mask, goggles. C. Gloves, goggles, gown, mask. D. Goggles, gown, gloves, mask. Before I reveal it, which one do you think is right? The correct answer is C. Gloves, goggles, gown, mask. C is correct because doffing removes the most contaminated items first. Gloves come off first, then goggles or face shield, then gown, and finally the mask or respirator, with hand hygiene at the end of the sequence completing the transition. A is wrong because removing the mask before contaminated gloves and gown brings hands and gloves close to the face and breathing zone, defeating the purpose of the doffing order entirely during patient care today. B is wrong because starting with the gown forces handling of fabric contaminated on the outside while gloves are still on, which then contaminates the gloves further before they themselves are removed at all. D is wrong because starting with goggles is incorrect because dirty gloves should come off first to prevent transferring contamination to the face and the parts of PPE removed later in the sequence during doffing. After wearing PPE in an isolation room, removing it incorrectly can transfer pathogens directly onto your skin or mucous membranes. The doffing sequence is a deliberate order designed to protect the healthcare worker during the transition out of precautions. Each layer of PPE accumulates contamination differently. Gloves and gowns bear the heaviest burden from direct contact, while the mask sits closest to the nose and mouth, the most vulnerable entry points to the respiratory tract. Donning and doffing run in opposite directions, a common exam trap. The donning sequence goes gown, mask, goggles, gloves. Doffing reverses the logic. Gloves come off first, mask comes off last. The CDC recommended sequence is gloves, hand hygiene, goggles, gown, then mask last, followed by final hand hygiene. Hand hygiene ideally occurs between steps and always at the very end before re-entering the clean corridor. When removing each item, technique matters as much as order. Gloves are pinched at the wrist and peeled inside out. Goggles are handled by the strap only. The gown is rolled inward. The mask is lifted off by the ties, never by touching the front surface. For the exam, memorize gloves first and mask last, with hand hygiene anchoring the start and finish. Any sequence placing the mask before contaminated outer layers brings dirty hands toward the face and is incorrect. Question 36. Which of the following drug pairs is a documented look-alike? Sound-alike risk involving an antifungal and an anti-seizure medication. Your options are A. Toradol and Tramadol, B. Lamisil and Lamictal, C. Adderall and Inderall, D. Celebrex and Celexa. What's your answer? Commit to one before I continue. The correct answer is B. Lamisil and Lamictal. B is correct because Lamisil is an antifungal and Lamictal is an anti-seizure medication used in epilepsy and bipolar disorder. They look and sound similar and have caused dispensing errors. Tall man lettering and confirming indication help prevent mix-ups. A is wrong because Toradol and Tramadol pair an NSAID with an opioid analgesic rather than an antifungal and an anti-seizure agent. So the pair does not match the description even though the two drugs share confusing spelling. C is wrong because Adderall and Inderall pair a stimulant with a beta blocker, neither of which is an antifungal or an anti-seizure medication. So the pair does not match the clinical descriptions provided in the pharmacy technician's call. D is wrong because Celebrex and Celexa pair an NSAID with an SSRI antidepressant, neither of which matches the antifungal and anti-seizure description, even though their spellings have caused real prescribing and dispensing confusion in clinical practice. Look-alike, sound-alike medications, ELISA drugs, are a leading source of preventable medication errors. When two drugs share similar names or packaging, dangerous mix-ups can happen at every step, from prescribing to dispensing to administration. The canonical ELISA pair on credentialing exams is Lamisil and Lamictal. They share 5 letters and similar pronunciation, yet Lamisil is an antifungal treating nail infections, while Lamictal is an anti-seizure agent used for epilepsy and bipolar disorder. Tall man lettering, Lamisil versus Lamictal, highlights the differing letters to break automatic misreading. Other high-yield LASA pairs include Toradol versus Tramadol, an NSAID versus an opioid, Adderall versus Inderall, a stimulant versus a beta blocker, and Celebrex versus Celexa, an NSAID versus an SSRI. None of these match the antifungal versus anti-seizure category, so reading the stem precisely for the drug class described is essential. Pharmacies and clinics use several strategies to reduce LASA errors: tall man lettering, separated storage, and indication confirmation. Confirming the indication, not just the drug name, is the most reliable safeguard, as a single callback clarifying a prescription for bipolar disorder can prevent a patient from receiving an antifungal of no benefit to their condition. Question 37. A patient extends an arm for a routine venipuncture without speaking. Which of the following types of consent is illustrated? Your options are: A. Implied consent through patient action. B. Written informed consent on file already. C. Court-ordered consent for treatment care. D. Surrogate consent under guardianship arrangement. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Implied consent through patient action. A is correct because implied consent is inferred from the patient's actions or circumstances, such as extending an arm for a routine blood draw after appropriate explanation, distinguishing it from written or verbal expressed consent for higher risk procedures. B is wrong because written informed consent is required for higher risk procedures such as surgery, blood transfusion, or sterilization, where the provider documents discussion of risks, benefits, alternatives, and the patient's voluntary decision to proceed. C is wrong because court-ordered consent applies in specific legal situations such as TB treatment or psychiatric holds, and is not relevant to a routine venipuncture performed in an outpatient medical office setting today and tomorrow. D is wrong because surrogate consent is used when the patient lacks capacity and a designated agent or legal surrogate consents on the patient's behalf, which does not apply when an alert patient extends the arm freely. Implied consent is a special category of patient agreement communicated through behavior rather than words or signatures. Understanding how it works and when it does not apply is essential for any clinical setting. The classic example is a patient who extends an arm when a medical assistant approaches with a needle for a routine blood draw. That single voluntary gesture, after a brief explanation, legally communicates consent for the low-risk procedure. Implied consent is only valid when three conditions are all met. The patient has decisional capacity, the procedure is routine and low risk, and the cooperative behavior is clearly voluntary. If the patient is sedated, confused, or coerced, implied consent does not apply, and a formal process must be used instead. It is critical to distinguish implied consent from three confusables: expressed consent, where the patient verbally agrees; informed consent, the formal signed process for surgery or high-risk procedures; and surrogate consent, used when a patient lacks capacity. Implied consent never substitutes for written informed consent in surgery, anesthesia, or experimental treatment. On exam stems, watch for phrases like extends arm, rolls up sleeve, opens mouth, or presents for routine care. When a patient cooperates wordlessly with a familiar low-risk procedure, the answer is implied consent. Question 38. A patient suddenly collapses in the office and is unresponsive, with no pulse and no normal breathing. After calling for help, what should the medical assistant do first? Your options are: A. Wait for the AED to arrive on scene. B. Place the patient prone and clear the airway. C. Deliver 2 rescue breaths and reassess. D. Begin chest compressions immediately. Which would you go with? Lock it in before the reveal. The correct answer is D. Begin chest compressions immediately. D is correct because when pulseless and not breathing, immediate high-quality compressions begin without delay. The AED is applied as soon as it arrives, but compressions must not wait for the device, since every minute without circulation worsens outcomes. A is wrong because delaying compressions while waiting for the AED reduces survival, because every minute without circulation worsens neurologic and cardiac outcomes during cardiac arrest in any setting where bystanders are present today. B is wrong because prone positioning blocks effective compressions, and there is no airway obstruction described that would justify rolling the patient over rather than starting CPR right away as the algorithm directs. C is wrong because the current adult BLS sequence prioritizes compressions first, with breaths after 30 compressions, not 2 breaths before initiating any compressions in an unresponsive pulseless adult patient encountered today. When someone collapses without a pulse or normal breathing, every second determines whether brain cells survive. The current basic life support algorithm is built around one central insight: circulation must be restored before anything else. The American Heart Association now orders the steps as CAB: compressions, airway, breathing, replacing the older ABC sequence. Compressions come first because oxygenated blood is already in the lungs. What the brain needs is a force to drive that blood forward through the circulation. Effective compression requires placing the heel of one hand on the lower half of the sternum, layering the second hand on top with fingers interlocked, and pushing straight down at least 2 inches at a rate of 100 to 120 per minute. Full chest recoil between each compression is critical. It allows the heart to refill with venous blood before the next stroke. The urgency behind compressions first is straightforward. Brain cells begin dying within 4 to 6 minutes of zero cerebral blood flow, and survival drops roughly 7 to 10% for every minute of delay. Compressions cycle 30 to 2 with breaths, and should be interrupted as little as possible. Several common confusables each belong to a different clinical scenario. Rescue breaths first, prone positioning, the Heimlich maneuver, and the recovery position all have specific roles, but none of them precedes compressions when a patient is pulseless. On any exam stem confirming absent pulse and absent breathing, compressions are always the first physical action. Question 39. Which of the following best describes the AMA Medical Assisting Code of Ethics for medical assistants today? Your options are A guide for billing and coding accuracy. B, pledge to respect human dignity. C, a set of state laws governing licensure procedures. D, a federal regulation enforced by HHS today. Don't overthink it. Which one feels right? The correct answer is B, pledge to respect human dignity. B is correct because the AMA Code of Ethics commits medical assistants to render service with full respect for human dignity, protect confidential information, uphold honor, improve knowledge, and participate in service activities that benefit the community. A is wrong because billing and coding accuracy is governed by federal and payer rules, including the False Claims Act and CMS guidance, not by the AMA Code of Ethics, which addresses professional behavior and patient relationships only today. C is wrong because state laws govern licensure and scope of practice rather than the AMA Code of Ethics, which is a voluntary professional code adopted by the association rather than enforced as a state statute today directly. D is wrong because the AAMA Code of Ethics is not a federal regulation enforced by HHS. It is a professional code adopted by the Association to guide medical assistant behavior and uphold patient dignity in everyday work. The American Association of Medical Assistants publishes a code of ethics that sets professional expectations for medical assistants in clinical practice. Unlike federal laws or state licensing statutes, this code is a voluntary professional commitment adopted by the association itself. The code consists of 5 principles: respect for human dignity, protection of confidential information, upholding professional honor, pursuing continuous learning, and serving the broader community. These principles guide decisions that no specific law can fully prescribe. Consider a medical assistant who overhears a colleague discussing a patient's sensitive diagnosis in a public hallway. Reporting the breach to a supervisor and refusing to participate both reflect the code's second principle, respecting confidential information. It is critical to distinguish the IAMA code from other frameworks. HIPAA is a federal privacy law. State practice acts govern licensure. The False Claims Act covers billing integrity, and the Joint Commission sets facility standards. None of these is the IAMA code, even though several share overlapping values. When an exam stem mentions the IAMA code of ethics, think voluntary professional self-governance. Not statutes, not regulations, not payer rules. Dignity and confidentiality are its central commitments, anchoring the ethical texture of every patient encounter. Question 40. A clinic implements a brief daily team huddle before morning sessions in a patient-centered medical home. Which of the following best describes the primary purpose? Your options are: A. Replace formal staff meetings entirely. B. Discuss salary and compensation issues. C. Review the schedule and anticipate needs. D. Conduct disciplinary performance reviews. Got a guess? Lock it in. The correct answer is C. Review the schedule and anticipate needs. C is correct because daily huddles last 5 to 15 minutes and review the day's schedule, identify high-risk patients, confirm needed orders or materials, and anticipate problems. They support team-based care and proactive workflow management for the practice. A is wrong because huddles complement rather than replace longer formal staff meetings. Strategic discussions, training, and operational issues still require scheduled meeting time outside of the brief daily huddle window devoted to clinical workflow preparation each morning. B is wrong because compensation discussions are private personnel matters handled by managers individually. They are not appropriate for an open team huddle focused on the day's clinical workflow planning, patient preparation, and care gap closure activities for the team. D is wrong because disciplinary reviews are confidential one-on-one conversations between an employee and a supervisor in private. Huddles focus on collective patient care preparation rather than on individual performance feedback evaluations or formal disciplinary actions for staff members. The team huddle is a brief, structured stand-up meeting held at the start of each clinical session. It exists to align the entire care team around the day's work before the first patient arrives. In those 5 to 15 minutes, the team reviews the schedule, flags high-risk patients, confirms that needed orders and equipment are in place, and closes care gaps before they become problems. Effective coordination requires every role at the table: providers, medical assistants, nurses, behavioral health staff, pharmacists, and front desk personnel each contribute context that no single person holds alone. On exam questions, watch for confusables. A performance review is a private supervisory conversation. A departmental staff meeting runs longer and covers strategy. A quality improvement meeting focuses on specific measures. The huddle is none of these. It is short, frequent, and anchored entirely to the clinical day ahead. When an exam stem mentions a brief daily meeting focused on schedule review and anticipating patient needs, that is the huddle. Distinct from any meeting concerned with personnel matters, formal evaluation, or longer-term improvement work. Question 41. A medical assistant must send a business letter notifying a patient of an upcoming procedure. Which of the following formats places every line flush left? Your options are a modified block business letter format, B. Semi-block business letter format, C. Simplified business letter format type, D. Full block business letter format. Which one is it? Pause the video if you need more time. The correct answer is D. Full block business letter format. D is correct because the full block business letter format places every line flush left with single spacing within paragraphs and double spacing between paragraphs, making it the most common format used in professional medical correspondence. A is wrong because modified block format places the date, complementary close, and signature block at the center of the page, with the rest flush left, which differs from the all flush left full block format described. B is wrong because semi-block format follows modified block but indents the first line of each paragraph, which is not the same as full block where every single line including paragraph starts is flush left. C is wrong because simplified format omits the salutation and complementary close and uses an all-cap subject line, which differs from the full block format that retains traditional salutation and closing entirely flush left. Business letters in a medical office follow standardized layouts to look professional and make information easy to find. The most widely used arrangement today is the full block format, which gives correspondence a clean, uniform appearance from top to bottom. In full block format, every element, the date, inside address, salutation, body paragraphs, complementary close, and signature block, sits flush against the left margin. Single spacing is used within paragraphs, and a blank line separates each paragraph from the next. It's important to distinguish full block from its close cousins. Modified block centers the date and closing while keeping body text flush left. Semi-block adds paragraph indentation on top of that. Simplified style drops the salutation and complementary close entirely, replacing them with an all-capital subject line. Full block format exists for both visual cleanliness and machine readability. When letters are scanned into electronic health records, a consistent left margin reduces optical character recognition errors and makes archived documents easier to retrieve. On the exam, watch for signal phrases like every line flush left, no indentation anywhere, or single left margin. These almost always point to full block. References to centered dates or indented paragraphs indicate one of the other named formats instead. Question 42. Which structure of the brain coordinates voluntary movement, posture, and balance? Your options are A. Cerebellum, B. Medulla oblongata, C. Hypothalamus, D. Pineal gland. Take a second. Which answer would you pick? The correct answer is A. Cerebellum. E is correct because the cerebellum sits posterior to the brainstem and coordinates voluntary movement, posture, and balance. Damage or disease here produces ataxia, intention tremor, and difficulty with smooth coordinated motion in patients. B is wrong because medulla oblongata is part of the brainstem and controls vital autonomic functions, including heart rate and breathing rhythm, so it does not coordinate voluntary movement and balance like the cerebellum. C is wrong because hypothalamus regulates homeostasis, including temperature, hunger, thirst, and hormonal release, but it does not coordinate voluntary movement, posture, or balance the way the cerebellum does in the body. D is wrong because pineal gland produces melatonin and helps regulate sleep and wake cycles, so it does not provide the fine-tuning of voluntary movement and balance that the cerebellum performs in the central nervous system. The cerebellum is a compact but neuron-dense structure tucked beneath the occipital lobes. Despite making up only about 10% of the brain by volume, it contains more than half of all the brain's neurons, and its job is fundamentally about precision. The cerebellum has 3 core functions: fine coordination of voluntary movement, maintenance of upright posture, and moment-to-moment regulation of balance. It achieves this by working in concert with the motor cortex, the vestibular system, and proprioceptive signals from joints and muscles. The motor cortex initiates a movement command, but the cerebellum compares that intended movement against real-time sensory feedback from the body. When a mismatch is detected, the cerebellum sends a correction signal back through the thalamus to the motor cortex, smoothing out what would otherwise be jerky, overshooting motion. The cerebellum is organized into distinct regions. The flocculonodular lobe manages vestibular balance, the vermis handles trunk posture, and the lateral hemispheres control limb coordination. Purkinje cells, the large output neurons of the cerebellar cortex, integrate sensory and motor signals throughout all of these regions. On the exam, words like ataxia, intention tremor, dysmetria, and wire-based gait should immediately point you toward the cerebellum. Remember, the cerebellum is the only structure that integrates ongoing sensory feedback to refine movement in real time, distinguishing it clearly from the basal ganglia, medulla, hypothalamus, and pineal gland. Question 43. An older adult with mild hearing loss arrives with her adult daughter, who answers all questions for her. Which of the following adjustments should the medical assistant make? Your options are: A. Speak only to the adult daughter. B. Cover the mouth while speaking softly. C. Face the patient at eye level. D. Shout questions across the exam room. Before I reveal it, which one do you think is right? The correct answer is C. Face the patient at eye level. C is correct because facing the patient at eye level with clear lip movement in a well-lit room helps a patient with hearing loss participate directly, preserving autonomy and improving the accuracy of the history obtained. A is wrong because speaking only to the daughter undermines the patient's autonomy, may miss important details, can feel disrespectful to the older adult, and bypasses direct communication with the actual patient during the visit. B is wrong because covering the mouth blocks lip-reading cues that patients with hearing loss often rely upon alongside any residual hearing or assistive devices being used during the medical office visit today and tomorrow. D is wrong because shouting distorts speech sounds, embarrasses the patient, and rarely helps hearing impaired patients understand better than clear, normal volume, face-to-face speech with appropriate lighting in the exam room today. When a patient has hearing loss, how you position yourself and use your face matters just as much as what you say. Most patients with hearing loss aren't completely deaf. They combine residual hearing with visual lip-reading cues to understand speech. Presbycusis, the age-related hearing decline, specifically erodes high-frequency sounds. Patients often hear vowels clearly, but miss consonants like F, sh, and lip movement supplies exactly those missing consonant cues. The technique involves several deliberate adjustments. Position your face at eye level in good light. Speak at a normal conversational volume rather than shouting. Slow your pace slightly. And rephrase rather than simply repeating when the patient doesn't understand. Reducing background noise from TVs or hallway chatter also meaningfully helps. Eye-level positioning does 3 things at once. It enables lip reading by keeping your face visible and illuminated. It signals respect to the patient, and it preserves patient autonomy by ensuring you speak directly to the patient rather than defaulting to a family companion. On the exam, Correct answers involve facing the patient, eye-level positioning, a well-lit room, and direct communication. Shouting, covering the mouth, or speaking only to a family member are wrong answer signals. Each one breaks the technique and undermines patient-centered care. Question 44. A patient asks how oxygen reaches body tissues. The medical assistant should explain that oxygen is carried by which of the following? Your options are A. Albumin, B. Fibrinogen, C. Globulin, D. Hemoglobin. What's your answer? Commit to one before I continue. The correct answer is D. Hemoglobin. D is correct because hemoglobin is the iron-containing protein inside red blood cells that reversibly binds oxygen in the pulmonary capillaries and releases it to peripheral tissues. It also helps transport carbon dioxide back to the lungs. A is wrong because albumin is a plasma protein synthesized by the liver that maintains oncotic pressure and transports various substances. So it is not the iron-containing oxygen carrier protein found inside the red blood cells. B is wrong because fibrinogen is a plasma protein produced by the liver that converts to fibrin during clot formation, so it does not function as the iron-containing oxygen carrier within circulating red blood cells in the body. C is wrong because globulin describes a class of plasma proteins including immunoglobulins involved in immune defense and transport, so it is not the iron-rich oxygen-binding protein contained within circulating red blood cells in the body. Hemoglobin is the iron-containing protein inside red blood cells responsible for nearly all oxygen delivery in the body. Understanding its structure and behavior explains why blood can carry so much more oxygen than plasma alone ever could. Each hemoglobin molecule has 4 globin chains, 2 alpha and 2 beta, each paired with a heme group containing a ferrous iron atom. Because each iron atom binds one oxygen reversibly, a single hemoglobin molecule carries up to 4 oxygen molecules. Hemoglobin multiplies blood's oxygen carrying capacity roughly 70-fold compared to dissolved plasma alone. It also handles about 23% of carbon dioxide returned to the lungs and buffers blood pH through its histidine residues. When the first oxygen binds, hemoglobin shifts from the tense state to the relaxed state, raising affinity at remaining sites. This cooperativity produces the sigmoidal dissociation curve. In working tissues, low oxygen, higher carbon dioxide, and acidity trigger the Bohr effect, causing hemoglobin to release oxygen readily where it is needed most. A key exam skill is distinguishing hemoglobin from other blood proteins. Albumin maintains oncotic pressure, fibrinogen drives clot formation, and globulins include immunoglobulins for immune defense. Only hemoglobin, packaged inside red blood cells rather than floating free in plasma, performs oxygen transport. Question 45. Which imaging modality uses powerful magnets and radio waves rather than ionizing radiation to evaluate the brain and spinal cord? Your options are A. Computed tomography, B. X-ray radiography, C. Magnetic resonance imaging, D. Mammography. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Magnetic resonance imaging. C is correct because magnetic resonance imaging uses strong magnets and radio frequency pulses rather than ionizing radiation, producing detailed soft tissue images. It is preferred for evaluating the brain, spinal cord, joints, and other tissues with subtle contrast differences. I is wrong because computed tomography uses ionizing radiation and combines many X-ray slices to create cross-sectional images, so it does not match the description of a magnet-based study with no ionizing radiation. B is wrong because X-ray radiography uses ionizing radiation to produce projection images of bones and dense structures, so it does not match the magnet-based detailed soft tissue brain and spinal cord study described. D is wrong because mammography uses low-dose X-ray imaging specifically for breast tissue screening and diagnosis, so it does not match the magnet-based brain and spinal cord study described in this imaging selection question. Magnetic resonance imaging creates detailed cross-sectional images using strong magnetic fields and radio frequency pulses. Play what? No ionizing radiation involved. Understanding how and why it works helps clarify when it outperforms every other imaging modality. Hydrogen nuclei in water and fat naturally align with the scanner's powerful magnetic field. What? Typically 1.5 or 3 Tesla. Thousands of times stronger than Earth's field. A radio frequency pulse disturbs that alignment, and as protons relax back, they emit signals that encode tissue properties like proton density, T1, and T2 relaxation times. Different pulse sequences highlight different tissue properties. T1 weighted images make fat bright and fluid dark, ideal for anatomy. T2 weighted images make fluid bright, revealing edema and inflammation. Diffusion-weighted imaging detects acute stroke within minutes, and gadolinium contrast reveals breakdown of the blood-brain barrier. MRI's greatest advantage over CT and plain radiography is soft tissue contrast, brain-gray matter, white matter, CSF, ligaments, and early ischemic lesions that look identical on X-ray are clearly differentiated on MRI. CT is faster and better for bone and unstable trauma but delivers ionizing radiation. Ultrasound is also radiation-free but limited by depth and bony structures. Safety screening is critical before any MRI. Ferromagnetic implants such as older aneurysm clips, cochlear implants, and certain cardiac pacemakers may be absolute contraindications. Metallic foreign bodies in the eye pose serious risk. All removable item, jewelry, hearing aids, credit cards, and bobby pins must come off before entering the scanner room. Question 46. Which of the following parts of Medicare covers outpatient clinic visits and laboratory tests? Your options are Part A, B Part B, C Part C, D Part D. Which would you go with? Lock it in before the reveal. The correct answer is B, Part B. B is correct because Medicare Part B covers outpatient services, including provider visits, preventive care, and laboratory testing. Part A covers hospital and skilled nursing care. Part C is Medicare Advantage. And Part D covers prescription drug coverage in private plans. A is wrong because Part A covers inpatient hospital care, skilled nursing facility care, and limited home health rather than the clinic visits and labs the patient asked about. So it does not fit the routine outpatient services described in the scenario. C is wrong because Part C is the Medicare Advantage option that bundles A and B benefits through approved private plans rather than directly answering which traditional Medicare part covers outpatient services in the original program structure. D is wrong because Part D covers prescription drugs through private plans rather than outpatient clinic visits and lab tests. So it does not match the services the patient asked about during his question about routine office care today. Medicare Part B is the outpatient and medically necessary services component of original Medicare. It fills a critical gap left by Part A, which only covers inpatient hospital stays, by extending coverage to the settings where most Americans receive everyday care. Part B covers a broad range of services including physician office visits, outpatient hospital care, diagnostic lab tests, durable medical equipment, ambulance transport, mental health services, and a defined list of preventive screenings. Part B is voluntary and funded through monthly premiums adjusted by income. After meeting the annual deductible, Medicare pays 80% of the allowed amount, and the patient or a Medigap supplemental plan covers the remaining 20% coinsurance. A key exam skill is distinguishing the four Medicare parts. Part A covers inpatient hospital, skilled nursing, and hospice. Part B covers outpatient and preventive care. Part C bundles A and B through private plans, often adding dental and vision. Part D covers outpatient prescription drugs. Billing under Part B uses the CMS 1500 form for professional services. The Medicare Physician Fee Schedule calculates allowed amounts using relative value units adjusted by geographic practice cost indices. Medicare then reimburses 80%, leaving 20% for the patient or their Medigap plan. Question 47. Which of the following federal laws requires emergency departments to screen and stabilize all patients regardless of ability to pay? Your options are A. Emergency Medical Treatment and Active Labor Act. B. Genetic Information Non-Discrimination Act of 2008. C. Americans with Disabilities Act of 1990. D. Patient Self-Determination Act of 1990. Don't overthink it. Which one feels right? The correct answer is A. Emergency Medical Treatment and Active Labor Act. A is correct because the Emergency Medical Treatment and Active Labor Act requires hospitals with emergency departments to provide a medical screening exam and stabilize any patient who presents, regardless of insurance or ability to pay. B is wrong because the Genetic Information Non-Discrimination Act prohibits discrimination based on genetic information in health insurance and employment, but does not address emergency department screening or stabilization obligations of any kind in hospitals. C is wrong because the Americans with Disabilities Act prohibits discrimination based on disability and requires reasonable accommodations, but does not specifically address emergency department screening or stabilization obligations of any hospital or facility. D is wrong because the Patient Self-Determination Act addresses advanced directive education for facilities receiving Medicare or Medicaid and does not address emergency department screening, stabilization, or the obligation to treat without payment today. EMTALA is a federal law passed in 1986 that guarantees emergency care regardless of a patient's ability to pay. It applies to any hospital with an emergency department that participates in Medicare, which is the vast majority of hospitals in the United States. Before EMTALA, hospitals practiced patient dumping, transferring uninsured or low-income patients in active emergencies to public hospitals without first stabilizing them, sometimes with fatal results. Congress stopped this by tying screening and stabilization obligations to the Medicare Provider Agreement. EMTALA imposes 3 duties on every emergency department. First, every patient must receive a medical screening examination. Second, if an emergency condition is found, the hospital must provide stabilizing treatment before discharge or transfer. Third, any transfer must be appropriate, with accepting facility confirmation, record sent, and qualified transport. It is critical to distinguish EMTALA from similarly tested laws. HIPAA governs health information privacy. The ADA addresses disability discrimination. Think wheelchair access or sign language interpreters. The Patient Self-Determination Act covers advanced directives and living wills. GINA protects against discrimination based on genetic information. The exam signal phrases for EMTALA are medical screening exam, stabilization, active labor, and regardless of ability to pay. Screening always happens before insurance verification. That sequence is the law's intent and a favorite test detail. Question 48. A construction worker arrives at urgent care after a chemical splash to one eye. Which of the following techniques is most appropriate for the medical assistant to use during irrigation? Your options are A. Irrigate from outer canthus to inner canthus. B. Use cool tap water for a brief flush. C. Instill mydriatic drops before flushing. D. Tilt head with affected eye lower and flush. Got a guess? Lock it in. The correct answer is D. Tilt head with affected eye lower and flush. D is correct because chemical eye exposure requires copious irrigation with sterile saline for at least 15 minutes, with the affected eye positioned lower than the unaffected eye to prevent splashing fluid from contaminating the uninjured side during the flush. A is wrong because directing fluid from outer to inner canthus drives debris and chemical toward the medial canthus and over to the unaffected eye, contaminating it during the irrigation procedure being performed in urgent care today. B is wrong because tap water briefly is far too short for chemical exposure, and sterile saline is preferred over tap water in any clinical setting where saline and emergency eye wash are both readily available. C is wrong because mydriatics dilate the pupil but do not address the chemical injury, and instilling them before flushing wastes critical irrigation time during the highest yield window for limiting injury to the eye. Chemical eye exposure is a true ophthalmologic emergency. The window for limiting injury is extremely narrow, so the very first action is immediate. Continuous irrigation, before history taking, vision testing, or pH measurement. The affected eye is positioned lower with the head tilted towards that side. Sterile saline flow from the inner canthus, the corner near the nose, outward toward the outer canthus. So contaminated runoff drains away from the healthy eye into a basin. Strong acids cause coagulation necrosis, forming a barrier that limits deeper penetration. Alkalis such as lye, ammonia, and concrete dust cause liquefaction necrosis. Drive in the chemical into the cornea and anterior chamber within minutes, making alkaline burns especially dangerous and requiring prolonged irrigation. Irrigation must run for at least 15 continuous minutes, even longer for alkaline agents. The eyelids must be held open because blepharospasm closes them tightly. A Morgan lens or topical anesthetic drops may be needed to sustain the flush. On the exam, look for copious saline irrigation, 15 minutes minimum, affected eye lower, and flow from inner to outer canthus. Any answer suggesting a brief flush. Tap water as first choice. Or an eye exam before irrigation is a wrong answer signal. Question 49. Which of the following best describes the receiver's role within the communication cycle? Your options are A. Encoding the original message clearly. B. Selecting the channel for delivery. C. Decoding the message and giving feedback. D. Generating background noise barriers. Which one is it? Pause the video if you need more time. The correct answer is C. Decoding the message and giving feedback. C is correct because in the communication cycle, the receiver decodes the message and provides feedback that confirms or clarifies understanding, completing the loop and allowing the sender to adjust the message as needed today. A is wrong because encoding is performed by the sender, who selects words, tone, and channel before delivering the message. This step occurs before the receiver decodes and responds within the communication cycle today and tomorrow. B is wrong because selecting the channel is part of encoding by the sender, who chooses verbal, written, electronic, or non-verbal delivery before the receiver interprets the message and provides feedback within the cycle today. D is wrong because noise refers to environmental, physiological, or psychological barriers that interfere with clarity. It is not a role within the cycle, but rather an obstacle that participants encounter during the message exchange. The communication cycle is a model that breaks down how messages travel between people into discrete, teachable stages. Understanding each stage lets you pinpoint exactly where a breakdown occurs and correct it before it causes harm. The cycle has 6 elements. The sender encodes an idea and transmits it through a channel. The receiver decodes the message and returns feedback to close the loop. Noise. Environmental, physiological, or psychological, it can distort any stage along the way. For the exam, role assignments are precise. Encoding and channel selection belong to the sender. Coding and providing feedback belong to the receiver. Noise is not a role, it is an interference category that can disrupt any stage. Noise works like static on a phone call. The sender transmits clearly, but distortion prevents accurate decoding. Recognizing the source of that state, whether it is a loud environment, hearing loss, or patient anxiety, is the first step toward repairing the breakdown. When a STEM asks who decodes the message or provides feedback, the answer is the receiver. When it asks who chooses words or picks the medium, the answer is the sender. Teachback is the classic feedback technique that confirms the receiver decoded the message correctly. Question 50. A patient cannot stick out the tongue straight and it deviates on protrusion. Which cranial nerve is most likely affected? Your options are A. Cranial nerve 5, B. Cranial nerve 12, C. Cranial nerve 9, D. Cranial nerve 7. Take a second. Which answer would you pick? The correct answer is B. Cranial nerve 12. B is correct because cranial nerve 12, the hypoglossal nerve, supplies motor fibers to the muscles of the tongue. Damage causes deviation of the tongue towards the affected side when the patient is asked to protrude it. A is wrong because cranial nerve 5 is the trigeminal nerve, which provides facial sensation and motor fibers to the muscles of mastication. So it does not produce tongue deviation when the patient protrudes the tongue. C is wrong because cranial nerve 9, the glossopharyngeal nerve, supplies taste at the back of the tongue and pharyngeal sensation. So its injury affects swallowing and gag rather than producing tongue deviation on protrusion. D is wrong because cranial nerve 7 is the facial nerve, which controls facial expression muscles and taste on the front of the tongue. So its injury produces facial droop rather than tongue deviation. Cranial nerve 12, the hypoglossal nerve, is a pure motor nerve dedicated entirely to tongue movement. Its nucleus sits in the medulla oblongata, and its axons exit through the hypoglossal canal to reach the floor of the mouth. The nerve emerges between the pyramid and the olive in the medulla, passes through the hypoglossal canal, and fans out to supply the genioglossus, styloglossus, euglossus, and intrinsic tongue muscles, all working together for precise tongue movement. Normally, both genioglossus muscles pull symmetrically, keeping the tongue mid-line on protrusion. When one hypoglossal nerve is damaged, the intact contralateral muscle overpowers the weakened side, and the tongue deviates toward the side of the lesion. Atrophy and fasciculations may also appear on the weak side. Several neighboring cranial nerves share oral and pharyngeal territory, so distinguishing them is a key exam skill. Cranial nerve 5 affects chewing and facial sensation. 7 produces facial droop. 9 governs a gag reflex. 10 causes ovular deviation and hoarse voice. And 11 controls shoulder shrug. Only 12 drives tongue protrusion. The bottom line, tongue deviation on protrusion is a specific localizing sign for cranial nerve 12. The tongue always points toward the damaged side, whether the lesion is peripheral or involves upper motor neurons crossing from the opposite cortex.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.